Ma'am, we are in live, ma'am.
Very good evening to one and all of you, dear friends. And EYEEDU has been part of our academic activity of the Eye Foundation group of hospitals. And truly, we've had a series of very good webinars, thanks to so many of you in different parts of our country. And our viewership has also been very nice. And I'm sure this is going to take off beautifully, troubleshooting in oculoplasty. We are truly lucky to have on the expert panel with us Dr. Santosh Honawar, who's the Honorary Secretary of AIOS and also the Director of Medical Services for the Center for Sight Group of Hospitals based at Hyderabad. We are truly happy to have with us Dr. Vijay Rangarajan, who is the Chief of Orbit Oculoplasty and Ocular Oncology Services from the Arvind Eye Care Systems, Coimbatore. Thank you, Dr. Vijay. We are really lucky to have with us our dynamic Kasturi Bhattacharya, who's member ARC East, and of course, more importantly, director of the clinics and academics of Shankardev Netralaya, Guwahati, and she is going to give us tons of wisdom. And we are very lucky to have with us Dr. Saptagirish, who's the head of the Department of Orbit and Oculoplasty and also the Dean of the Shankara Group of Eye Hospitals based at Bangalore. Actually, I'm the co-moderator. Moderating this session is Dr. Vidya Muralidhar, who is a senior consultant oculoplasty and ocular oncology, a gem of our Eye Foundation group of hospitals based at Coimbatore. And we shall start off without wasting time. Our first speaker is going to be Dr. Linnea Thomas, who is a specialist in orbit and oculoplasty, and she's going to talk on something so very important, red flags in epiphora. On to you, Dr. Linnea. Dr. Linnea, are you there with us?
Yes, ma'am. Thank you, ma'am.
Yeah.
I'll share the screen.
Linnea Thomas has joined us as a part of the Eye Foundation group of hospitals. And temporarily, she's with us in Coimbatore before it goes and joins in our Kochi center. On to you, Linnea.
Thank you, ma'am. Good evening to all. First of all, I want to thank Dr. Chitra.
Sorry,
Hello.
this is a presenter view, ma'am. Yes, ma'am.
Is it in presenter view now or normal view?
This is okay, Linnea. It's in
normal view. Yeah. Okay. Can I start, ma'am?
Please start, Linnea.
Okay. Good evening to all. First of all, I want to thank Dr. Chitra ma'am and Vidya ma'am and the entire Eye Foundation for giving me this opportunity. Today, I'll be speaking on the red flags in epiphora. So what we need to understand is epiphora is not synonymous with DCR. In other words, all patients with epiphora are not going to get benefited with a simple DCR alone. So today we will be discussing some of such scenarios. For that, first we need to have an understanding of epiphora. So epiphora simply means watering or tearing. And this happens as a consequence of either excessive production of tears or inadequate drainage. So there are two entities, one is a true epiphora and one is pseudo epiphora. True epiphora occurs whenever the inadequate drainage happens and this results in watering. And when it happens due to excessive tear production, we call it as hyperlacrimation or pseudo epiphora. So once you identify true epiphora, you have to again see whether it is an obstructive type due to an anatomical blockage in the drainage pathway or is it because of physiological reasons. So coming to history part, a good evaluation always begins with a good history taking. because it provides a clue to the diagnosis, especially in cases of children. So some of the key points which we have to keep in mind while we are taking history is, one is the time of onset, because a congenital NLDO usually presents shortly after birth. Anything that presents few months later, we have to further evaluate the cause of the epiphora. Coming to laterality, mostly NLDOs are all, or lacrimal drainage obstructions are all unilateral. Something which is bilateral, we have to think about dry eyes or ocular surface irritation, some other causes. The type of discharge is also important, because usually lacrimal drainage obstructions produce mucoid or mucopurulent discharge. Watery discharges usually in case of dry eyes. So intermittency of the epiphora is very important, because constant watering is what we see in case of NLDOs, complete NLDOs. So if you are going to see an intermittent epiphora that is going to exacerbate with upper respiratory tract infection, that gives us a clue that this may be because of the partial obstruction. Then we have to ask about prior facial trauma histories and orbital radiation histories and use of certain ophthalmic medications like anti-glaucoma medications, and history of prior sinus nasal surgeries or SAC surgeries. Now we are coming to certain scenarios. So first picture shows a patient post usage of dorzolamide, second patient post burns, and third patient post radiotherapy. All these patients presented with epiphora. So these are conditions of inflammation. So inflammation, what happens is it leads to progressive fibrosis that can result in obstruction. This may be at the level of the punctum or canaliculus mostly. So in these cases, just doing a DCR is not going to help. First, we have to remove whatever is the inciting agent, and then we have to start them on topical or systemic steroids. Once the inflammation is settled, then we can plan about the recanalization procedure like a punctal dilatation or a canalicular stenting. So this is a case of ichthyosis, and next is a case of angular blepharitis. So ichthyosis is a systemic disease, and it has to be managed systemically first. And angular blepharitis is going to present in a similar way with epiphora and itching and maybe a swelling in the corner of the eyes, because constant rubbing can cause obstruction at the level of punctum, canaliculus or sac, and it can lead to a permanent occlusion. Here again, first we have to treat the inflammation first. First go for the topical steroids, and once the inflammation settles, we can plan about the recanalization. Again, coming to cases of trauma. So first is a case of soft tissue injury with canalicular tear, and second and third cases. Second picture shows an immediate presentation after a naso-orbital ethmoidal fracture, and third is a late presentation. So if in case of a soft tissue injury with canalicular tear, we have to address it immediately. So within 48 hours or as early as possible, we have to do a stenting. While in case of naso-orbital ethmoidal fractures, what we have to we have a wait and watch approach. So whenever there is a fracture, we can just address the fracture. We can go for reconstruction of the fracture and wait for the lacrimal drainage obstruction. That means we can, if it is presenting immediately or if it is presenting later also, we can always go for a CT or a CT DCG to find out if there is any NLD involvement or bony impingement of NLD. And if so, we have to find out at what level it is using CT DCG. Once it is confirmed, then we can wait and watch, and then we can go for a DCR or conjunctival DCR at a later stage. So delaying the procedure is not going to affect the result as in case of a soft tissue injury. Even in case of medial canthal injury, first you have to do a probing. We have to find out whether there is any lacrimal drainage obstruction. If so, we have to address that, and then we have to go for the canthopexy. So history of previous surgeries, this is a case of post-maxillectomy following tumor resection. So in these cases, this is very important. One thing we have to see for any nasolacrimal duct injury post-maxillectomy. Second thing is we have to see for any residual tumors. So an imaging is very important in this case to look for any residual mass. And if so, we have to remove the residual mass, and then we have to plan about the drainage surgeries. Now coming to mechanical obstruction. So first picture shows a carangular mass, and second picture shows conjunctival calluses. So these are going to obstruct the punctum mechanically. So in these cases, whatever is the cause, we have to remove. So you can go for a carangular mass excision, or the redundant conjunctiva, you can just excise, and that will relieve the obstruction. Coming to neoplastic cases, so the secondary acquired lacrimal drainage obstruction can either occur from primary tumors of the lacrimal drainage system or a secondary infiltration by the lid tumors. As you can see in the picture, a BCC or a meibomian gland carcinoma can infiltrate into the lacrimal drainage system, and it itself can cause. Any mass extending above the above the medial palpebral ligament or a patient presenting with bloody discharge always requires a further evaluation. You have to always think of tumor and look for any signs of lymphadenopathy. And once you are suspicious about it, you have to go for an imaging. So when you do the imaging, you can go for CT orbit. You can go for a CT orbit and CT paranasal sinuses, including the lacrimal fossa. So once it is suspicious, you have to go for a closed or open biopsy. Once that is done, you have, and if it is confirmed, then you have to treat the tumor first, and then we have to wait for another 5 years. Even in cases of obstruction of the lacrimal drainage system, we usually adopt the dictum of waiting for 5 years to see whether there is any recurrence of the mass. So once you are sure that in 5 years there is no recurrence, then you can go about with the surgeries. Coming to infections, we have first picture shows canalicolitis and second is an orbital cellulitis, secondary to an acute dacrocystitis. So in these cases, the acute infection has to be treated. Canalicolitis you can treat with a topical or oral antibiotic, and you can actually express out the material, the granular material from the canalicus. And later, once the infection is settled, you can go for recanalization or you can go for curettage. Then coming to orbital cellulitis, again, the acute infection has to be treated, and then you have to go about with the lacrimal drainage obstruction. So this is a picture showing an abscess, and second is a picture showing a fistula because of the rupture of the abscess. So in these situations also, the acute infection has to be treated first, and in case of fistulectomy, later in the later stages, you can plan for a DCR with fistulectomy. So ectropion, entropion because of the trichiasis, and entropion because of the trichiasis, and ectropion because of the irid laxity and the associated lag of thalamus and punctum displacement can cause watering. So in these cases, you have to do a surgical, we have to surgically correct these conditions. That is going to help in avoiding the epiphora. Now coming to anterior rhinoscopy, so these three things we have to see. One is the gross DNS will result in less room to operate, which can result in failure of DCR. And atrophic rhinitis again might cause a DCR failure because of the unhealthy mucosa. And third, a nasal or sinusoidal mass again can cause obstruction at the distal end of NLD. So these three cases, you always have to refer to an ENT surgeon, and you need clearance of all this. And after that, you can plan for the surgeries. So the take-home message is all patients with epiphora are not just going to be benefited with a DCR or with DCR alone. First, we have to differentiate between a true epiphora and pseudoepiphora. Once a true epiphora is diagnosed, identify the site and course of obstruction and plan the management accordingly. In case of secondary obstruction, always treat the cause first and then deal with the lacrimal drainage obstruction. Thank you.
Hello. Hello.
Yes, yes.
Yeah.
Yes.
That was a wonderful talk. Wonderful talk. So very crisp and clear and linear. I have a question for the expert panel, a very basic question before Vidya takes on. As a cataract surgeon, I would like to know that would you do a DCR in any case of obstruction? Dr. Kasturi?
Yes, the most important nowadays, we don't do a syringing.
इनकी आवाज ही तो आने दो.
We usually do a row plus. Okay. So in case you find there's a row plus, then I would prefer to do a DCR before the cataract surgery. But in case there's row plus negative, it does not mean that there is no obstruction. There can be obstruction, there can be a fibrotic sac, and this can also lead to a DCR, a row plus negative. So even if you have a row plus negative, the patient comes with epiphora and gives a history of chronic epiphora, then it's important to do a conjunctival swab and you do a gram stain or a culture before taking up to be medico-legally safe. But if it's a frank row plus, then it is advisable to do the DCR operation.
Yes, Dr. Vidya?
Ma'am, Linya has pointed out all those complex scenarios in the case like post-traumatic abstraction or an external scarring or combined mechanism epiphora. That usually is require innovative thinking, and also we need to provide unique solution to the particular scenario. How do you typically handle these scenarios?
Yes, what I feel, when you describe epiphora, Lina has described very nicely, but we know epiphora means something related to here. So if it can sub-classify it as an etiology related to the punctum, to the canaliculus, to the sac, to the duct, and the nose, it becomes very easy. Because one by one you can rule out, because we know the most common is punctum, then followed by the sac, right? But there are some causes that there may be epiphora, but if you do a syringing, it is patent. So what happens, those are the functional obstruction. You need to know the causes of those functional obstruction. You need to cause it. A palsy can also lead to an epiphora, even a myasthenia gravis, anything like Parkinsonism, which all affects a blink mechanism. So whenever you get an epiphora, it is evident that anything related, like when we talk about epiphora, we always talk about ocular causes, lid causes, and the nasolacrimal cause, right? So ocular cause, we already know ophthalmos, chronic conjunctivitis, we know the lead cause, which has been mentioned very well. But the most important, what are the causes which is responsible for the epiphora in relation to the duct, the whole system, the NLDO system. So she had really mentioned, but it would have been better if you could have incorporated all the findings, like because many a time the paralytic cause also can lead to an epiphora.
That's true, ma'am. And if at all we need to do a combined mechanism epiphora, do we do in one go or we do in a stage procedure, ma'am? Like ectropion and CDC. So first treat CDC and then go for ectropion correction, or combine it both together.
If you
So
ask
which
me,
would be better?
I usually do both. I
Do-
usually do because both are external, but nothing related to intraocular. If it is
Right.
intraocular, it must be separated at least. Textbook says it is 6 weeks, but I approximately wait for 3 to 4 weeks. But if you want to go to the textbook, it says that the minimum period is 6 weeks. But anything which is extraocular, you can do it combined, because follow-up is usually a problem because they come from so far distance. It will not cause. Sometimes even I do blepharoplasty and entropion together.
Right. And another problem is that cases with non-obstructive epiphora, which is again, many of the post-cataract surgery patients do have this kind of problem. And on syringing, it will be patent, but they don't have obvious lid laxity also. But there can be some trivial conditions like conjunctival chalasis. Do you treat all those conditions, or how do you go about it, madam?
Post-cataract epiphora is very important. Do you know one of the most common cause of post-cataract epiphora is because of the steroid that we use.
Use.
The steroid causes myopathy. So because of steroid, it affects the blink mechanism. So it's a very important cause. Sometimes we think that it is because of conjunctival chalasis, or we think that because some people doing SICS, they hold the superior. No, it is a steroid induced. And moment you have to tell the patient that once you're done with the steroid course, you start with a blinking exercise, you'll feel that the epiphora improves.
Thank you so much, ma'am. Thank you.
Yeah, so we shall go on to our next speaker, Dr. Sendil Nathan, who again is a very well-known ophthalmologist of our country. He's based at his Ramna Eye Center at Chennai, and he's going to take us on to challenges and complications of the lacrimal surgeries.
Thank you, madam. Thank you very much. The outset, I'd like to thank Dr. Chitra Ramamurthy for this wonderful opportunity. Can you see my screen?
Yeah, we can.
Yeah. So today I'm going to speak to you on challenges and complications of lacrimal surgeries. So basically, we all know DCR surgery is a very commonly performed surgery. It has excellent results and the steps are very predictable. But sometimes when you do these surgeries frequently, you'll be faced with unusual situations. For example, multiple failed surgeries, or extensive facial trauma, or distorted anatomy, or bilateral simultaneous acute dacrocystitis or chronic dacrocystitis, or patients with serious systemic contraindications. So I'm just going to take you over some of the out-of-the-way presentations which we had to handle and which will be of benefit to you. So this was one such patient who had come from Iraq actually with a bullet injury to his right eye and a blowout fracture with the associated NLD obstruction. You can see his eye is blind, and he also had a keratoconcavenous fistula which is treated there in Iraq. And this patient had a blowout fracture with NLD obstruction, and he wanted he wanted cosmetic correction, and he wanted the watering to stop. So how do you approach this patient? Do you do both simultaneously or do it in a sequential manner? So what we planned was, you can see the CT scan of this patient. He's got a huge blowout fracture. You can see the coils inside his cavernous sinus, which is there. And this is how he came to us. Extensive scarring. He's got a depressed malar eminence also. So what we planned was, we planned to go through the old scar itself in the cheek and approach both the blowout fracture and convert it into a DCR incision as well. Just extend it superiorly so that you can gain access to the lacrimal sac. And so we first did the DCR, the usual steps. And after doing a 2-flap DCR, we proceeded to correct the blowout fracture. We placed a titanium mesh with a bone implant, and we closed the incision after injecting some amount of 5-FU and steroids. And you can see postoperatively, he's done quite well. The significant improvement in the inophthalmos, and also the NLD obstruction was taken care of. So through a single incision, you can do both the DCR and the blowout fracture in the same sitting. This was one more interesting patient, a patient with multiple neurosurgeries. She had craniostenosis, so she had almost 8 to 9 neurosurgeries in the past, and she presented us with NLD obstruction on one side. And you can see her nose also has been reconstructed with a flap. So she did not have a proper nose, and the whole anterior part of the nose has been reconstructed. So how do you do a DCR in such a patient? So you can see this patient's got an artificially constructed nasal bridge and a nose, and you can see the multiple plates on a skull there. And you can also see plates very close to the cribriform plate as well. So if this patient comes to for you with watering, how do you do a DCR? What precautions do you take? So basically, these patients, you have to be very careful, because patients with multiple neurosurgeries, usually the cribriform plate is not that strong. And if you do a standard DCR and you try to take bone too superiorly, anterior superiorly, you might end up causing a CSF leak. So you have to be cognizant of this fact. You have to be very careful when you're doing the ostium superiorly. You have to see the scans pre-op, and you have to make sure that the position of the cribriform plate. And if it is a low place cribriform plate, you have to be very careful not to go too superiorly. And also, like I said, this patient has got an artificially constructed nose, so her nostril is very narrow. So you have to place a pack very carefully. And also, again, when you're doing the ostium anteriorly as well, anterior superiorly, you have to be careful, because there's not normal bone, nasal bone there. Midway, the bone stops and you have a artificially reconstructed nose. So you don't do a very large anterior ostium. So if you take these basic precautions, you can have good results. And this is one more different patient with trauma. You can see he's got a depressed nasal bridge fracture with an NLD obstruction. And in the CT scan, you can see a depressed nasal fracture there. And in this patient, you do a standard DCR. Again, take precautions that when you take bone anteriorly, the bone is not very strong. So if you do aggressive enlargement of the ostium superiorly, you can actually worsen the nasal fracture there. All these cases, you have to be very careful, and you have to check the position of the cribriform plate in the CT scan. That's very, very important. If they have a low place cribriform plate, you have to be very careful when you're doing the ostium superiorly. Always use new rongers, sharp rongers. Don't use blunt rongers. Don't twist and turn the ronger. That is when you can have a fracture which spirals onto the cribriform plate. You can have a CSF leak, which is a serious complication. Actually, this patient who had the surgery actually had a inflammation post-op with a discharge from the wound. And we treated him with antibiotics, but it was not settling down. Finally, we found out that the nasal implant which had placed was infected. So once we opened up and removed that nasal implant, he settled down beautifully. And you can see the silastic tube also which you have placed. Most of these complicated DCRs, you always have to intubate them. That's very important. And as much as possible, try to take 2 flaps, so anterior and posterior flap, so that the chance of your success rate is high. I do not have experience with mitomycin, but I know some colleagues who routinely place mitomycin C applications when they do a complicated DCR. This again is a very unusual case. You can see this patient actually is a neurosurgical postgraduate, and he had a very horrible road traffic accident with a big frontal bone fracture and also orbital fracture with NLD obstruction. And this patient, you can see we opted to do an external DCR. And the same precautions again. All these patients with fractures or neural problems, you have to be careful when you're doing the ostium superiorly. Don't twist, don't do aggressive bone punching superiorly. And this patient did very well. And you can see we also did a frontal bone reconstruction in the same sitting through the previous incision. And this is after nasal reconstruction, squint surgery, and the frontal bone reconstruction. You can see he's got a very good cosmetic outcome as well. So in patients with multiple problems who present to you with NLD obstruction, don't try to do only the DCR in one sitting. Like Dr. Kasturi was saying, you can always try to see how much procedures you can add on to the same sitting so that you give the benefit for the patient, single general anesthetic, and try to correct as much problems as possible in the same sitting, and approach the patient holistically with an aesthetic outlook as well. You have to try to make the patient look as good as possible after your surgery. So don't concentrate only on the DCR. Try to add on as much procedures as possible so that you give the best aesthetic outcome for the patient. Again, this patient who had a 5-time failed DCR, you can see the multiple incisions which have been made. And this is how we presented for the 6th time to me. And how do you place the incision in such a patient? So many times incise, and you can see the zigzag scar there. So how we planned was we placed it through the same old incision and converted the old scar into a double Z-plasty type of incision. So that apart from gaining access to the old scar, you can also combine a double Z-plasty once you have done the DCR, so that you also remodel the scar. And this patient also had a very good outcome. And this is a very, very interesting patient. I've shown it many times. And this patient is a Crouzon's patient who came for a craniofacial reconstruction. And in craniofacial surgery, what they do is they place a bicoronal flap like this, and they reflect it completely over the face of the patient to gain access to the both orbits at the same time. But however, when the neurosurgeon and the ENT surgeon were doing it, accidentally they had cut both the NLDs. You can see when you reflect the flap over the orbit, you have the NLD which goes in the nasolacrimal duct, which goes into the fossa. And if you're not careful, the surgeon actually had cut the NLD, and we are left with a very strange situation where both the NLDs were cut when the patient actually did not come for this problem. And luckily, I was also there in the theater. And what we planned to do was we tried to do an intubation, a silastic intubation. And since only the NLD was cut, you don't actually need to do a DCR. It's enough if you identify the cut edges of the NLD, the proximal and the distal edge, and pass the tube through the bony NLD and bring it up to the nose. And that's what we did. And we were very successful in reconstructing the NLD. I'll show you a short video of this procedure. And you can see, yeah. And you can see this is how we do. What you do is you first pass the silastic tube, you dilate the punctum, pass the silastic tube. But the only problem is this patient has got a bicoronal flap. So you need to lift the flap now, and you have to see underneath. And you have to see where the silastic tube is coming. That is the proximal cut end of the NLD. And once you pull the tube out of the proximal cut end, and then you identify the distal cut end of the NLD, which will be right in the bony canal. And once you've taken the silastic tube, now you pass the metallic part of the silastic tube into the bony canal, which is right there. And once you pass it through the bony canal, you use an endoscope and pull the metallic part through the nose. Only thing is you need to keep placing the flap to and fro so that you can pass the metallic probe through the punctum and then lift the flap and see where it is coming out inside, and then pass it through the bony NLD. So that's what we are doing now. We have identified the cut ends, both the upper and lower puncta. We have passed the silastic tube. And now we are going to pull the tube through the nose. So now we are placing the endoscope through the nose, and you can see the tube come out there through the valve of Hasner there. And then you pull the tubes out and you tie the silastic tube in the nose. And we were very successful, and this patient had excellent outcome post-op. And so you do the same thing both upper and lower. And again, this is not only did we reconstruct the NLD, you can see the dramatic cosmetic outcome. You can see a Ptosis surgery has been done, and we also did a squint surgery later on. You can see the huge difference in the cosmetic appearance of the patient. So that is what you have to aim. And this again is a very complicated case, a patient with a fibrous dysplasia, a lot of bony remodeling, operated multiple times, and by ENT surgeon who had an en bloc resection of the ethmoid and the frontal bone done. He landed up with NLD obstruction. And how do you approach such a patient? You can see the significant hypothalamus, the ptosis, the huge enlarged orbit on the left side, a lot of bony hypostosis, and with NLD. So what we did was on these patients with all these bony problems or even a traumatic NLD, you will find that the bone is very, very thick. So in these patients, using a bone punch sometimes does not work because you cannot pierce the bone, you can't pass the rongeur and get a good grip of the bone. So you need to use what is called as a bone drill. So this again is very, very important. So a bone punch will not work because normally we're all used to having the thin ethmoidal bone and the frontal process of the maxilla, which the rongeur beautifully fits. But in these cases, even in traumatic NLD patients, the bone is hypoosteotic. You have very thick bone. So you need to use a bone drill. And once you use a bone drill and have a good ostium, then the remaining part of the bone, you can use a rongeur and complete it. And also, it's not uncommon. You'll have a hypostosis of the periosteum as well. And you can see that's what's happening. We made an ostium, but on the medial side, you can see the periosteum actually is become almost like bone here. And we are removing the hyposteotic periosteum. And once you remove the periosteum, only then can you pass the silex tubes into the DCR ostium after making the flaps. So again, you can see the dramatic cosmetic difference apart from having a successful DCR surgery being performed. This is again after multiple surgeries, not one. He almost had 4 or 5 surgeries, and this is his final outcome. And this again is not an uncommon presentation. Sometimes you'll have patients who have bilateral NLD obstructions. This patient actually had ethmoidal plating done for RTA, a presentation with the bilateral NLD obstructions with acute acrosteat on one side and had a failed DCR on the other side as well. So what we did was we did IND first and treated the acute dacryocystitis. You can see the X-ray showing the bilateral ethmoidal plates. So we plan to do a bilateral single-stage DCR with tubes, and she did very well. And this is her, got married and also has a kid now. This condition is again a very important thing. What do you do for patients who have bilateral NLD obstructions? Do you do it single-stage sequential, or you do it in 2 separate stages? So what we usually do is the patient is quite fit and healthy. We do a single stage bilateral external DCR or endo DCR, and we have had very good results. The only thing which you have to be careful is it will help if you can take 2 flaps so that the bleeding is much lesser, and you need to be quick because most of the times we do this patients on local anesthetic, and it's important for you to finish the surgery as early as possible. And we had very good results which we published as well. And a few take-home points on taking 2 flaps for DCR. Sometimes most surgeons take a single flap, but when you're doing this complicated cases or you're doing cases which have failed many times, it'll help if you can try to get 2 flaps. And that's again important. Most of the times you might not be able to get, but in your routine cases of standard first-time DCRs, you try to make 2 flaps when the anatomy is normal, when the mucosa is healthy. It's quite simple. Once you incise the sac, you can see very obviously you can make 2 flaps very easily. And the challenge is when you come to the nasal side. In the nasal side is where most people are apprehensive. But again, once you make a head-shaped incision, instead of sacrificing the posterior flap of the nasal mucosa, you make a good flap and make it lie down posteriorly. And all you have to do is anastomose the posterior flap of the sac and the nose. And it is not actually very difficult at all. And the advantage is you have a
1 minute left.
Yeah, you have a bilaterally lined tube. You can see the 2 flaps which are in this is a periosteal levator. I'm making sure we are into the nose. And you can see that's the sac, that's the nasal flap. That's the nasal flap, yeah, and that's the sac flap medially. That's the anterior flap, anterior nasal flap. And this is after the posterior nasal lacrimal anastomosis. You can see the mucosa anastomosed beautifully. And after that, you go ahead and just make anterior anastomosis, and that's the anterior anastomosis. So this will enhance your results tremendously. Again, one more common question is, when do you do DCR, when you don't do? After 6 years, do you do DCR, DCT? There's no contraindication to doing DCR at any age. The oldest I have done is 94 years. You can see these patients tolerated very well. If they are systemically fit, no contraindications, you can boldly do a DCR. Again, we have a lot of challenging cases. For example, this patient, multiple RTAs, significantly fractured the nasal bone, or you'll have syndromic patients like bilateral strain syndromes, where you have to do it in sequential manner. You do a socket and lid reconstruction first, and then try to do the DCR next. And the moral of the story is, however the tough the presentation is, you try to approach it in a sequential manner, never give up, and you will definitely get good results. Thank you.
Oh, that was an amazing, mind-blowing presentation, Dr. Senthilnathan. 3 cheers to you.
Thank you,
Really
madam. Thank you.
very useful. I just wanted to take a question with Dr. Santosh. Dr. Santosh, you're there? Dr. Santosh is not there. Dr. Saptagirish? Doctor, are you there?
Dr. Saptagirish messaged that he'll be joining in 15 minutes. He was traveling. He just reached home, it seems. He'll
Dr.
be traveling.
Vijay,
Vijay is there.
yeah, Dr. Vijay, are you there? Yeah, so a very basic question I'm going to ask you all. We know that such complex surgeries as you all do, achieving hemostasis is the key. So what are your tips for achieving hemostasis in all your surgeries? Some essential tips. Can you unmute yourself?
Am I audible now?
Yeah.
Yes, ma'am.
Yeah, I think first, if the patient is on any anticoagulants or if the patient is a hypertensive, then the anticoagulants has to be withheld before surgery after the physician's opinion. And if the patient is on antihypertensives, that has to be controlled. Or if the patient is on antiplatelets, that also has to be withheld till the surgery is over. And then second is a good block, like infratrochlear, infraorbital, dorsal nasal, and anti-ethmoidal block. They are very important. And third is you do a good nasal packing with xylocaine and adrenaline drops. So the pack where we place is very important. It has to be anterior and superior. We should not push it posteriorly into the nose. So that is very important. And also next is your dissection. We should not, when we do the dissection, we should not use a blade or anything. Just do a blunt dissection of the muscles and all the soft tissues. We should not just cut with a blade or just nag it with a, with a tissue forceps or anything like that. So blunt dissection of the muscles and soft tissues is very important. And even the nasal mucosa, you can just blanch it with little bit of xylocaine adrenaline injection before you cut it. So all this will help, and you also keep the patient in a slightly reverse Trendelenburg position, the head end slightly elevated. So these can help in and always keep this bone wax ready because in case you have an emergency where there's a bleeding, then you need to use a bone wax or something. Usually we don't get that much of bleeding, and DCR is one procedure where apart from cataract, I think you get a very good success rate. That's what I feel. Yes.
Yes. Thank you very much, Dr. Vichi. Vidya?
Yes, ma'am. Like Dr. Sendil sir, it was an excellent presentation, and you nicely enumerated all the complications of DCR and various management strategies to address the complications as well. And you had also highlighted the importance of right patient selection to minimize the complications. Could you please elaborate more on the critical aspect of post-operative care to ensure optimal healing and outcomes? What all we should be doing and what all should not be done? Can you please elaborate on that?
Post-op, the most important thing is since you have a nasal anastomosis, it's important the patient should not blow his nose or sneeze or lift weights. At least for 2 weeks is the most important time, because up to 2 weeks you can have a epistaxis, secondary hemorrhage. So after 2 weeks, the risk comes down gradually. So that is one thing. The other thing is doing endoscopy, I felt is very important, though not in routine cases. Sometimes you will see, you will think the patient has got a failed DCR. Sometimes a patient complains of watering, and you do a syringing, and you actually have a regurgitation, and you think the ostium is closed and your surgery has failed. But I've seen patients, when you do endoscopy, you'll actually find a big blood clot sitting in the ostium. And once you just gently take off the blood clot using an endoscope and suction, you'll find the NLD is freely, the ostium is freely patent. So again, that's a very invaluable tool in your armamentarium. Doing an endoscopy is very important.
When will be this first endoscopy, sir? Post-op?
Usually, if the patient is completely asymptomatic, says he's completely fine, there's no watering at all, I do it at 2 weeks. I don't do it too early because, the patient can sneeze and all that when you pack the nose. So I do it after 2 weeks. But if the patient is complaining, if the patient has got watering, when you do a syringing, you find there's regurgitation, I'll definitely do an endoscopy and see what's happening inside.
Okay, right, sir. So, and for a novice lacrimal surgeon, what are the long-term complications of DCR that we should be mindful of, and what are the approaches that we can take to address them, sir? Any long-term complications or anything that we need to keep in mind?
Two things. One thing is, like I said, any surgery nowadays, what we perform is aesthetic surgery. So there's nothing, even whatever you do, even evisceration, enucleation, you have to aim to give maximum cosmesis to the patient. Ultimately, that's what the patient is concerned. So your scar placement, how you close the wound, where you place your incision, that is again very important. And the second thing is, like I said, again, in my hands, I feel if you are able to make two flaps and have a double-lined ostium, that is the best, because even when they do endoscopic DCR, you will see that most of the top surgeons, they don't leave the posterior end bare. They always cover the posterior end with a flap. They don't leave bare bone at all, because they found that when you leave bare bone, that actually stimulates granulation formation, and you can have a narrowing of the ostium post-op. So as much as possible, I try to take two flaps routinely. If the sac is very small, if I have a very complicated surgery, or if not possible, then I will make a single flap. And if needed, I'll intubate. So my advice for a novice surgeon is, if you have any doubts, you're not able to take two flaps, you at least intubate regularly, so that you're sure that there's a passage between the sac and the nose, and you have a tube in place, so that it does not get obstructed and cause a failure.
Excellent, sir. Excellent.
Dr.
Vijay ma'am, I just want to ask one last question in this thing. Is there any particular technique that you have personally found effective in enhancing your success rate in DCR, madam? Any particular tip or any particular step? Emphasize.
Unmute yourself.
Unmute, ma'am. Still you're mute.
Now?
Yes, ma'am.
Yeah. I think it's mainly proper case selection.
Okay.
Okay. And good anesthesia, good incision, achieving good hemostasis, dissection, and making a proper ostium. Like, it's not like you have to make a 10 mm into 10 mm. You go by the anatomical location and breaking proper flaps and intubating wherever it's indicated. So these steps, I think, if you can follow, and which are given in all the atlases and textbooks, I think you can do a proper surgery.
So the simple thing is concentrate on all steps, you'll be successful. Yes, ma'am.
Yes.
Thank you. Thank you.
Yeah, proper case selection is very important. Don't take, for a novice, don't take trauma, don't take acute cases, and don't take cases which the patients are having some tumor or any polyp in the nose. I know all this should not be dealt by a novice.
And
Dr. Kasturi, what's the critical difference between a pediatric DCR and an adult DCR? Some one or two highlighting points.
Yeah, 2 points. In continuation with the previous discussion, I feel for the novice, we should always mention that the secondary hemorrhage. The secondary hemorrhage usually occurs after 8 days, 7 to 8 days. And the two major causes can be number one, infection, and number two is dislodgement of the clot. So we should tell the patient that they should not be too much of moving around, and they should be near an eye hospital or ENT hospital. In case there's any secondary hemorrhage, they can come to an ophthalmologist or to an ENT specialist. And regarding the bleeding that you're mentioning, basically there are three reasons of bleeding. One is the angular vein, and that we can really prevent it by making an incision, either medial, approximately 5 millimeter, just medial to the medial canthus, and not going more than 4 millimeter above the MPL, right? Secondary bleeding can be from the nasal mucosa, and third bleeding is by the nutrient vessels. So if we can manage all these, main causes of this bleeding, then definitely the chances of intraoperative bleeding is also much less. VG has mentioned all of them very well, but these are some of the points that I like to just highlight. Secondly, mentioning about the pediatric DCR and the adult DCR, I feel pediatric DCR is really easy. Like what we say, the white eye blow fracture is something like a white DCR. The bleeding is very less, the bones are very thin. It is a much easy process, but you should have a good amount of ostium, because they are so reactive, the tissue is so reactive, the chances of again the membrane formation or the regrowth of tissue is high. sometimes what I do in the pediatric cases, just to be a safer side, and especially when my fellows do, I ask them to put a intubation also, especially the Mesterka. Mesterka has really changed our, treatment in pediatric cases, because it is something like a, I think everyone must have seen, it is something like a, what is a Monaka tube, which can directly go inside into the NLD and beyond up to the nose. So then when the child comes, after 2-3 weeks or so, you can just remove it. You don't have to do any other manipulation. So I feel pediatric is easy, but you should know the anatomy very well, and the bleeding is less, but the chance of closure can be high.
Ma'am, I just have one question. Can I ask Madam Chitra, Madam, if it's okay?
Yes, it's asked.
Yeah. Actually, for a pediatric DCR, when you put a Mastercard, do you find the patients are cooperative enough to take it off in your outpatient itself? Because you need to go to the punctum and pull it out, no?
Yes.
If it's a 4 or 5-year-old child, does it make a difference putting a bicanalical intubation and a Mastercard for a 4 to 8-year-old child? Do you think they're cooperative enough where you can manage to take it off?
Exactly. Pediatric, it is much easier to take out if you put a Mastercard. But if you put a bicanalicular, you have the knot, you need to see with the endoscope, or you might have to sedate them, then you need to cut it. So sometimes I ask my fellow just to put the Mastercard itself.
Thank you. We go on to our next speaker, Dr. Ganesh Kumar, who is a faculty in the Department of Ophthalmology of Dhanalakshmi Srinivas Medical College. And his practices exclusive orbit and oculoplasty at Trichy. And we look forward to hearing from him on strategies for a successful lacrimal surgery. On to you, Dr. Ganesh.
Hello, am I audible?
Yes, you're audible. Yes.
And
Make
is my screen visible?
Screen is
Screen,
visible.
full screen, sir.
Slideshow.
I've actually put it in slideshow only.
It's not in slideshow.
Is it okay now, madam?
No.
Sir, open your presentation, sir, first.
Presentation. Your presentation is not open.
Oh, can you tell me what are you seeing on the screen?
So
We are
first
seeing
open-
folders. Velmurugan,
Sir,
could you guide
open
him?
your presentation and go to share screen option and choose your presentation, sir. It will work.
I have to open my presentation. Okay, I've done that.
Yes, sir.
Now I go to share screen.
Share screen.
Yes.
Sir, make it full screen, sir, if possible.
Yeah. Is it okay now?
No.
Sir,
Can you?
slideshow is not visible.
I put it in full screen only.
No, it has not come on full screen here. Can you go on the way you have slide after slide? What is to do?
Yeah.
Should we, Velmurugan, could you work it out with him? We go on to our next speaker and come back to him.
Okay, ma'am. Sure. Welcome.
Dr. Shruti, you're there? So we would
Yes, ma'am.
go on to our next speaker, Dr. Shruti Tara, who is the Chief Medical Officer at the Shankara Group of Eye Hospitals based at Coimbatore. And she is going to talk on all that is droopy is not simple ptosis. On to you, Dr. Shruti.
Is my screen visible?
Yeah, slideshow.
Yeah. So in the next couple of minutes, I'll just take through a compilation of ptosis with the
with a twist. So I'm not going to touch upon the typical congenital ptosis or the aponeurotic ptosis that we normally see. So this child presented to us with ptosis, you can see he also had restricted elevation and hypotropia. And this was the patient with monoocular elevation deficit. So in these patients, they will be having squint, and if you just do a ptosis correction and give a full optimal correction of ptosis, the cornea might not tolerate it. Also, they will have a very obvious squint. Plus, they will have some amount of pseudotosis. So when the squint is corrected, the amount of pseudotosis gets, certain amount of pseudotosis gets corrected, and the residual ptosis we can operate. So here I have done a tarsofrontal sling after the ptosis, after the squint correction with a deliberate undercorrection. So this was another patient with the microcornea and microphthalmus, and this patient had congenital fibrosis of the extraocular muscles. So this gives an apparent enophthalmus, and that looks like as if the patient has got ptosis. So this was another patient with ptosis. She had serous carcinoma of the breast. And this is probably one condition where the metastasis can cause enophthalmus and then gives an appearance of ptosis. So this we all know is a neurofibromatosis, the S-shaped ptosis. And so this was another patient who had a ptosis and had the neurofibromatosis correction done with the anterior lamella shortening and removal of the excess skin. And you can see that there was some amount of ectropion. So I went in and did a shortening of the posterior lamella to give her an optimal correction of this kind. And mechanical ptosis, we are all aware of. A child with capillary hemangioma or any tumor of the lids can cause a mechanical ptosis. And this was another child with a bilateral congenital ptosis with telecanthus and epicanthus inversus. They have hypoplasia of the superior orbital rims, horizontal shortening of the eyelid, hypertelorism, and hypoplasia of the nasal bridge. Yes, it is blepharophimosis syndrome. I prefer doing it as a two-stage procedure. I know Dr. Kasturi here does it in a single stage, but I prefer a two-stage procedure. And this is the commune ducts technique of skin redraping. So you can see that the telecanthus is corrected. And next we would be operating on the squint. So this is another patient with, you can see that there's a deep superior sulcus. The patient has also got a crepey cigar paper-like appearance. And this is the blepharochalasis syndrome. And they have ptosis with sometimes there is laxity of the lid and causing ectropion. There is migration of the lateral canthus. Rounding of the lateral canthus can happen. And so here she underwent ectropion correction by lid tightening and Leicester's technique of inverting the lid. And also she had the levator was reattached back into the onto the tarsal plate. But the procedure is a little cumbersome here because everything is so thin and stretched out. But still we can get a reasonable correction. So this was another interesting case which our strabismologist shared. And this is a 15-year-old patient with a history of RTA and complained of drooping of the left eye since the trauma. And he did have diplopia in all case. So apart from the ptosis, he had 20 degrees of exotropia and mild hypotropia. So there was aberrant regeneration here. On attempted adduction, the ptosis improved. So you can see that there is ptosis here. On the patient is trying to adduct. There is ptosis is improved. And upon down gaze also, ptosis improved. So he had inverse Duane's and pseudo von Graeff's sign. So this was a traumatic third nerve palsy with aberrant regeneration. So what was done here was, he was operated on the unaffected eye with lateral rectus recession and medial rectus resection. So there is strengthening of the medial rectus on the opposite side, which was done. So this was the post-operative appearance. You can see that the ptosis has got corrected. So what we did here was, we took that this attempted adduction and ptosis which improved. So that concept was exploited here. So what actually it does is, when you recess or resect the contralateral eye, it forces, that is basically you're resecting the medial rectus and recessing the lateral rectus. It forces the contralateral eye in adducted position. So because of the Herring's law of equal innervation, what happens is the affected eye medial rectus gets triggered. So pulling it into an adducted position and the ptosis gets elevated. So that was one interesting case that we saw. And the motor, this is the routine, what we normally see is the Marcus-Gunn jaw-winking phenomena. There is something called as the Marin-Amat. So this happens in the seventh nerve where there is the eyelid closure on smiling. It's more of the blepharospasm, more like a blepharospasm because it's an innervation of the seventh nerve with the orbicularis. So when the patient smiles, there is ptosis, but it's not actually ptosis, but it is like a blepharospasm. So we have the inverse jaw winking phenomena also, where when the child opens the mouth, the ptosis gets exaggerated. So this was another patient who came with mild ptosis, but actually when you examine her a little more, you can see those spasms, so hemifacial spasm, and sometimes this can happen even in the aberrant regeneration of the seventh nerve. So this was yet another patient who presented with ptosis. So here history becomes very important. And when we did an ISPAC test, this was its appearance. Yes, this was the myasthenia. So the history of variability of ptosis over the day is important. So others are facioscapulohumeral muscular dystrophy, oropharyngeal dystrophy, CPEO, Kearns-Sayre syndrome. All these come under the myogenic ptosis. So again, these patients with myasthenia, they exhibit Cogan's twitch, fatigability, peak sign and all that. So repeated nerve stimulation, single muscle fiber EMG, acetylcholine receptor antibodies are what is normally done to rule that out. So probably a couple of years back, if a patient like this had come, he had myasthenia, I would have probably offered crutch spectacles. But now in certain cases, not all of them, but in certain cases when this was a patient who had myasthenia, you can see that, and also she had a gross amount of aponeurotic ptosis also, and you can see how bad the bells is, barely any bells. So what we did here was we did a tarsal switch. That is, took the tarsal plate from the upper eyelid and switched it to the lower eyelid and shifted her palpebral aperture to the center. So this you can see that how good the closure is. There is, if you do a routine ptosis surgery in these patients, so probably they will have corneal exposure. But with this, when we're shifting the palpebral aperture to the center, that can be avoided. So this was yet another patient of the similar kind. And with poor bells, you can see that there is barely any bells. This was, I operated one eye after the other. And you can see when both eyes are operated, he barely has any lag of thymus. So sometimes we come across patients like this with ptosis on one side and retraction on the other side. So this was a congenital ptosis on one side and congenital eyelid retraction on the other side. And so most patients prefer that the retraction be corrected. So I did a Mullerectomy on the retracted eye and to give him an appearance of this kind. And sometimes, most often times we do see like this, they come with droopy lids, but it's actually not droopy lids, the dermatochalasis. So with simple blepharoplasty, you can give them an appearance of this kind. And if they do have some amount of ptosis at the same sitting, you can correct that as well. So brow ptosis also is another reason to give an apparent ptosis. And this patient had a lateral brow pexy done, and you can see that he gets a good elevated eyelid kind. So when you see certain patients like this, they will have a mild ptosis, but please make sure to avert the lid. Sometimes you can come across tumors of this kind under the lid. And this is yet another rare condition that it is genetic, hypertrophic skin, excessive sweating, clubbing, periostosis, and arthritis. And this condition is called the pachydermoperiostosis. You can see that the skin is all very oily and open pores. And you can see such a large tarsal height is really large here. And of course, dacryoadenitis, the S-shaped lid. Infections can also present like ptosis. So this was a patient with cysticercosis, another patient of cysticercosis, and when treated adequately, the ptosis disappears. And it's not just the ptosis, you should also look at the proptosis associated with that.
Left.
Sorry?
No, 1 minute. Carry on.
Carry on.
Okay. Yeah. So this was a patient with pansinusitis, and this was a patient with lymphoma. My screen is hung.
Oh,
Yeah. Now, this was another patient. The corneal conditions also, we have to think this was a patient with the corneal OSSN with so much happening on the cornea. Sometimes they can present with droopy lids, and when treated, you can see that his ptosis is improved. So neurogenic ptosis we did touch upon. This is a routine third nerve, the simple third nerve palsy. Horner syndromes can have meiosis, anhidrosis, ptosis. Heterochromia and change in the color on the side of the skin when exposed to heat is seen mostly in children. And sometimes we do induce iatrogenic ptosis. This was a patient who had a dermalipoma excision elsewhere, an aggressive dermalipoma excision. Probably they had removed even the posterior extent, and posteriorly they must have disinserted the levator. The patient had very poor levator and severe dry eye and reasonably good bell. So after ptosis, this was her after the ptosis correction. So thank you very much. So that was
yes, Shruti, that was a brilliant talk. Vidya, could you take some very important questions? We have 5 more speakers. Hello, Dr. Santosh.
Hi.
I thought we'll plant a bomb in your place for boycotting our webinar.
Good evening, sir. And Shruti, you had mentioned all the essential conditions with all the potential risks that we as a clinician should be attentive to when addressing ptosis. In case of myogenic and neurogenic ptosis, what approach do you really favor in terms of management, Shruti? Could you please
yeah, in that's what like
unmute yourself?
Please
yeah,
unmute.
yeah. It depends on the amount of ptosis that you have. Like now, the myogenic ptosis that I showed there with the very poor pells. Off late, I have started doing this tarsal switch, and it gives a reasonably good results. The whole palpebral aperture, it's shifted to the center of the pupil, so the lid closure is adequate. And even if I want to do ptosis and give under correction, I would definitely prefer an anterior approach in these patients.
That's excellent, Shruti. Okay. And anything to
Even
Dr.
sling you
Santosh.
can,
yeah,
but you have to grossly undercorrect them.
correct them, yeah. And what about on those conservative management also is there very poor bells and where you
Yes,
cannot really correct it, you have
yes,
thought to
yes.
say. And I feel establishing an open communication with the patient is very crucial in these sort of cases, no, especially regarding potential outcomes and complications when we talk about. And how do you generally navigate and manage the situation?
Yeah,
What exactly you tell them?
generally, any ptosis patients, I spend a lot of time, actually, any patient for that matter. But ptosis, yes, I do sit with them and tell them all the risks and benefits, and then take up sometimes even the routine ptosis. I always tell them that there are chances for readjustments, under correction, over correction. So I spend some time with them and explain to them.
Dr.
And
Santosh, with
Mhm.
so many approaches to ptosis, so what is your most preferred technique for a complicated ptosis?
Depends on the complicated ptosis is a large basket. Shruti I think, has enumerated quite a few and very beautifully so. So each one deserves a customized approach. In fact, each patient deserves a customized approach. Like she was mentioning for myasthenia and chronic progressive external ophthalmoplegia, which are refractory to any other form of conservative treatment, etc. If a patient definitely has to undergo surgery, then you would either choose between tarsal switch procedure or a tarsofrontal sling with silicone. So it is customized to individual patients. So there is no thumb rule which can guide you in general management. You have to customize.
Dr. Kasturi, would you want to add anything?
I very much
Good
agree
topic.
with Dr. Santosh. Yeah, you really need to customize, but I feel one of a good technique for all this myogenic ptosis is definitely this sling, but even some amount of plication. If you just do a plication, it is much better because we do not get so much of lecophthalmos when we do plication. That is one which I believe. And otherwise, every procedure has its own advantage and disadvantages.
Thank you. Shall we go back to our speaker, Dr. Ganesh? Dr. Ganesh, can you share your presentation?
When he shares something new that has come up is medical management using oxymetazoline drops can alleviate ptosis by about 2 millimeter even in myogenic ptosis. So during work time, they can use it and they're happy about it. But unfortunately, that concentration is not available in India at this point in time.
Dr. Ganesh is having a problem there.
Right.
Dr. Ganesh, are you there? He was trying to share his presentation, so I thought we should hear him. Vidya, I think we need to talk to him. We go on.
I'll do, madam. I'll do, madam. I'll call him up.
Yeah. So anything else, Dr. Vijay, you had to tell?
Yes, ma'am. I just wanted to ask Dr. Kasturi. She said plication. How do you do that? You mean like just like a levator resection, or how do you assess?
Levator, and then if you perform approximately 8 to 10 millimeter, will correct 1 millimeter of ptosis. So
Yes,
it appears very nicely. Don't resect it. You just plicate it, take the suture in the tarsus, and then approximately 10 millimeter above, you just tie it. It gives a good correction, but leg of tenderness is less. So only 2 surgeries where I have seen the leg of tenderness is less. Post-operative is definitely one, the plication, and other one is frontalis muscle advancement. I feel that even frontalis muscle nowadays, I've totally switched off. Anything, if the ptosis is 3 millimeter below, I go for 100% frontalis advancement. There are reports like people are saying that they're having lash ptosis, this and that. But now I have started my technique where I make the arcus marginalis as a pulley. Through that pulley, if you pass it, then you will not have the lash entropy on. So even I have realized that these 2 conditions in my hand, the leg of tenderness is almost minimal.
thank you.
So, Dr. Kasturi, in patients with myogenic ptosis, so you just do only the plication?
Yes. Or
Or
CP.
plication along with sling? You're coupling it with?
No, initially I used to do sling, but CPO, I have a good series where I do only plication.
Over time, have you had any droop?
I gave this as a research project to one of my fellows almost 2 years back. So at least in the 2 years, some amount comes down, but it is good. Like optimus is not there. And anyways, also we don't correct the full ptosis. We keep them little undercorrected. But the people are able to do their daily activities. They can walk and they can see around. Between the 2, somehow I am feeling the plication is working good for the CPO patients.
Thank you.
But don't correct it totally or don't overcorrect it. They keep little undercorrected. And the most important is the bells. And sometimes I feel that one problem with a myogenic ptosis is the inverse bells. I have seen that. I don't know why the inverse bells is common. I don't know, Santosh, whether you agree to it or not. Normal, when we do a LPSR in normal ptosis, congenital ptosis or aponeurotic ptosis, we don't get inverse bells, right? But in myogenic ptosis, the chance of inverse bells is more, maybe because the edema is more in the superior part. Something may be there, but I have seen that.
It's a central phenomenon actually, and the way to prevent it is if you suspect that a particular patient has a higher chance of going into inverse bells, such as myogenic ptosis, or patients with double elevators under action or monocular elevation deficit, is to, if at all you want to use frost suture, that will be the standard frost, not the reverse frost. Reverse frost is where lower lid is frosted and tied to forehead. Otherwise, if you do the upper lid and put it on cheek, then that will prevent or minimize the risk of having a reverse bells.
That's why I wanted to ask. I mean, I think you have shown some amount of this myogenic ptosis, right? Have you encountered any of the inverse ptosis in such patient?
Yes, so whenever I have that, I immediately switch over to standard frost suture. So within a matter of 48 to 72 hours, it reverses back.
Dr. Ganesh, your presentation has not opened yet. We are only looking at your folders. Velmurugan, I think you should be guiding him properly.
Yeah.
I think we shall, Dr. Ganesh gets the slides sorted out. We go on to our next speaker, Dr. Jaya Gayatri, who's the Chief of the Orbit and Oculoplasty Services from Arvind Eye Care Systems based at Pondicherry. And she's going to take us on unveiling the complications in Ptosis surgery. On to you, Dr. Jaya. You need to sort out Dr. Ganesh's issue, please, Mr. Vedmurugan.
Yes, ma'am.
Warm good evening to the august audience present here. Is my screen visible, ma'am?
Yeah.
Okay, my heartfelt thanks to you, ma'am, for giving me this wonderful opportunity. After hearing Shruti ma'am's excellent talk on complicated ptosis, I'll be covering the complications that we encounter in ptosis surgeries. As usual, the classification can be pre, intra, and post-operative. Pre is most often a misdiagnosis, which ma'am has illustrated very well. The commonest being myasthenia, the missed strabismus, that is the double elevator palsy, and of course the unrealistic expectations either from the patient themselves or from the parent of the patient in case of a congenital ptosis. So pre-op counseling becomes very, very important. Sometimes we need to deliberately undercorrect. So that should not be taken off as a complication. Intraoperatively, the common one can be hematoma, especially in these situations where the patient is on aspirin and we had a huge hematoma which was not revealed, and next day we had to encounter a huge hematoma. There rarely in novice surgeon there can be an inadvertent injury to the globe, but the conjunctival buttonhole, especially during LPS resection using the anterior approach, is not uncommon. The postoperative complications, usually undercorrection, overcorrection, lag of thalamus, poor lid contour, and the asymmetric lid crease are little common, whereas ectropion, entropion, the eyelash ptosis, conjunctival prolapse, the lamella granuloma, and the suture exposure are little uncommon. The undercorrection, it can be seen either with a dorsofrontal sling or with an LPS resection. The most common causes being loosening of the inadequately reinforced facial knots, failure to raise the eyelid adequately before placing the facial knots. But it can be easily overcome if it is a dorsofrontal sling, because we can open up just the forehead wound and the sling can be tightened at any moment of time and the desired height can be obtained. Overcorrection. Overcorrection is a little risky because it leads to corneal exposure and keratopathy. In this young girl who was about to get married, there was an overcorrection following an LPS resection, and we had to resort to LPS recession. So we can obviously see two scar marks following two surgeries. So the trial of massage was done. Usually it is done in the first week of surgery. The downward traction on the lashes or even the lid eversion over a dimmer is retracted on the hospital setup. If it is not working, then through the transconjunctival wound, we can reposit with a iris repositor if the posterior approach of LPS has been used.
Hello?
Yes, ma'am?
Sorry, carry on, Jaygat.
Oh, okay, Vidya. So if there is 2 mm of lid retraction, we can handle it with a tenotomy. If it is 3 mm, we can do elevator recession. But if it is really 4 mm or more, then we may have to do a scleral graft. But if it is after a tarsofrontal sling, then we can just loosen this sling or cut the sling and redo it. Lag of thalamus. Lag of thalamus is a part and parcel of any ptosis correction. But as Kasturi madam said, the newer frontalis flap negates this complication. So immediate post-operative, we have to counsel the parents that children who are undergoing a sling surgery will have lag of thalamus for quite a duration of the time, and they have to be very strict with their lubricating drops and ointment. But who is at risk? Especially people in old age because of their inherent poor Bell's phenomenon. Patients with CPO and double elevator palsy are at greater risk. Suture granuloma, not very frequently encountered. It is a reaction to suture, most commonly in the posterior approach surgery, and we have to remove the granuloma with normal scissors, and the base has to be cauterized. Abnormal lid contour, of course, we will have to tackle it only by doing a redo surgery. Extrusion of the sling, it can be due to infection or it can be due to a foreign body reaction. So we can see that on the left, there is this boy has not actually, there is exposure, but there is a lot of infection going on in the whole sling tract, and it is, whereas on the right, we can see the child one side with an abscess and the other side with a extruded sling. Another patient with no evidence of infection, but an exposed sling after several years of surgery. Conjunctival prolapse occurs in a severe congenital ptosis where the dissection was carried out beyond the fornix or due to the excessive postoperative lid edema. A simple lubrication would work in these cases, or if need be, the conjunctiva has to be deposited with a muscle pool. The pang, if the conservative measures do not work, then the pang sutures, which is nothing but non-absorbable sutures through the conjunctiva, through the desired skin crease, are taken and left for 2 weeks. An entropion, usually encountered after excessive tarsal resection in Facinella cervix, when the anterior lamella is too long relative to the posterior lamella and the skin is not attached deeply to form a skin crease. The treatment would be to shorten the anterior lamella by excising a short strip of skin above the incision. Whereas the converse is true for ectropion, the anterior lamella is shortened too much, and or if the sutures are brought out too close to the lashes and tightly. So the skin below the incision should be undermined, recessed, and sutured at a lower level on the tarsus. Lash ptosis occurs when there is an aggressive dissection of the orbicularis muscle from the tarsus along with suturing of the LPS high on the tarsus. The treatment would be a gray line split with a formal skin crease formation, ensuring the suturing of skin edges tightly on the LPS or tarsus. A rare complication would be injury to the superior rectus muscle or a superior oblique muscle. To conclude, ptosis surgery is more or less a cosmetic procedure than a functional procedure, and we have to counsel the parents and the patients before surgery in order to have their realistic expectations so that we can handle the complications, if any, in a better way. Thank you for patient listening.
Thank you, Dr. Jaya, for a very thorough, complete talk. Dr. Vidya, can you take some questions?
Yes, Madam. Jai Gayatri, that was a wonderful talk. And I'd like to know the opinion of the expert members. What is the likelihood of adjustment over time? Like considering the factors like changes in patient anatomy, natural aging process, and also unexpected variation in the sling tension. And how do we achieve optimal and sustained lid elevation? Santosha, could you please?
Yeah, I think that is a utopian goal, to achieve constant correction or have a very durable procedure. That is almost impossible, especially if you operate earlier. So if a child, if you operate, then the chance of the child having undercorrection over a period of time is very high. If you operate in a stable adult, fully grown adult in late second decade or third decade, then the chance of having a durable surgery is very high. So depending on when you operate and what is the etiology. If you operate on an elderly patient with, say, acquired aponeurotic ptosis, again, it's going to be stable for several years. So in a child who's growing, there is bound to be some kind of undercorrection over a period of time. And also, if you have done sling, the chance of undercorrection is very high in a child when he grows into an adult, as opposed to levator resection.
Yes. And another problem is that dealing with lag off, which can be a persistent issue following sling surgery, or it can be levator excision that we have done for a Marcus gun jawing phenomena, or can be following a frontalis flap also. So what consideration should we keep in mind, sir, and how do we effectively manage this situation?
So only consideration that you can actually, as a precaution you can do is Shermer's test and assess Bell's very carefully and exclude the possibility of patient having any monocular elevation deficit. If you have excluded all this, then the only way you can deal with lack of thymus would be adequate lubrication, especially at bedtime. Taping is hardly ever required. I really haven't advised any patient nocturnal taping. But lubricants, many patients are still on lubrication even after 3 or 4, 5 years following surgery. Nighttime gel on the cornea if they have severe lack of thymus. The possibility of lack of thymus is higher if the patient has poorer levator action and if your resection is, supramaximal or maximal, and in patients who have undergone a tarsofrontal sling as opposed to any other form of surgery, including frontalis flap, the lack of thymus is going to be much lower. Patients who have undergone a Mullerectomy or Vascular Savart procedure are going to have much less lack of thymus than patients who have undergone maximal or supramaximal levator resection or Whitnell sling.
Does age also play a role in this, sir? Like if we do age also play a role in this, sir? Like levator excision, if we do at an early age for Marcus Gunn jaw winking phenomena, does it have an effect on lag of that the patient?
Marcus and jaw winking phenomena,
Yes.
if you excise or extirpate levator and do sling, then it will operate just like any other case of sling.
Okay.
Right? So obviously there will be more of lack of thymus and down gaze slit line.
Thank you. We shall now go on to our next speaker, Dr. Santosh. He's going to be talking on mastering the art of precise ptosis correction, tips for the novice, and the next 20 minutes, I'm sure, is going to be an enthralling moment.
Oh my God. So I thought Ganesh is going to do next.
No, I don't know what is. Vidya, were you able to look into Dr. Ganesh's?
Dr. Ganesh,
Madam, actually, I think there's a problem with my resolution of my presentation. So apparently, I will not be able to share it in the full screen mode. It is visible here, but it's not visible there.
No, then would you want to show it as without?
Yeah, I can show it in the normal mode. I've sort of made it maximum so which you can visualize. That should be acceptable, I think.
Okay. Anyway, Dr. Santosh has shared presentation.
Yeah, I'll
After
go next.
you go next.
Yes,
Thank
ma'am,
you.
I'll go next. Thank you.
Thank you, Chitra, for this wonderful symposium and including me as part of it. I'll be talking about surgical approaches to ptosis, especially for a beginner. Now, whenever you have a patient of ptosis in front of you, these are the questions that you need to ask yourself and answer. What is the severity of ptosis? Are there any complicating factors? Then you decide what surgery would I undertake. Then you also explore, is the surgery going to be safe for the patient? And what is the expected outcome? In some patients, complete correction or full correction and symmetry cannot be the expected outcome because there are limitations to each surgery, which I'm going to enumerate. And of course, you have to prevent complications that have been mentioned by the previous speaker. Now, when to operate is a question, especially in a young child like this. A newborn brought to you with bilateral severe ptosis, obviously that is not the right time to operate. But when the child is active, start sitting up with support, etc. And if the child has chin elevation of this sort or use of pro or frontalis, that is the time when you must intervene. And if at all you want to intervene in this patient, it has to be a temporary surgery, which is completely reversible and redone when the child reaches school-going age. This is one child where there was bilateral severe ptosis, but the father also has bilateral severe ptosis. He hardly has about 2 millimeter palpable fissure, but he has 6 and 6 vision. So bilateral severe ptosis generally does not produce amblyopia if a patient assumes head posture and also uses frontalis, however severe it may be. But if a child has unilateral severe ptosis, coming in the way of the pupil, then the chance of amblyopia and severe amblyopia is very high. And these are the patients we would select out for an early surgery. And that surgery generally has to be a reversible surgery, as I said. And one of the ways of doing a reversible surgery is to use sutures. There are many sutures that can be used, including Prolene, but what I use is Ethibond or polybutylate coated braided polyester, which is absolutely friendly to the tissues and can be easily reversed. So this 3-point technique, the epitarsal points have been marked about 8 millimeter apart. That's the forehead incision that's being made by a BP knife. You can see that we are making a guarded incision and then creating a prefrontal pocket for final burial of the suture. Because burying is important, otherwise you would encounter sling granuloma. Then for children under 1 year of age, you would use a 4-0 Ethibond sling. But for children over 1 year of age, you would tend to use a slightly thicker 308 bond sling passed in the epitarsal plane with the needle that is swatched to the sling, and then you have to chain the needle. This is a free needle. You have to enter from exactly the same point of prior entry. You should not leave a skin loop behind. It passes just the usual path of the sling, suborbicularis, under the septum, subrow tissues, and through the frontalis, and comes out through the prefrontal incision that you have made already. The gap between the two arms of the sling should be about 3 to 4 millimeter when it comes out through the frontal opening. Then somebody has to hold the knot for you to tighten. You tend to make a large knot, otherwise this sling knot can cheese wire through. If you just use the routine knot 2 or 3 throws, then it can cheese wire through. So you have to really make a large knot, and that can be done by tying it over 8 to 10 times. So that's the reason why you make a large knot. There is no other reason. So here I'm making a large knot, and then we don't leave it at that. You can see that the lid has been left about 1 millimeter behind the limbus. Now I pass it again in oblique meridia. This is to make sure that the cut ends lie flat under the frontalis, so that the chance of sling granuloma is nearly zero. Otherwise, suture slings tend to have a sling granuloma. Once I shifted to this technique, my incidence of sling granuloma is almost negligible. I haven't seen a sling granuloma in years. So this is how I pass it. And then I suture the frontal wound using a couple of 6-0 Vicryl sutures or catgut. You pull and cut so that the cut end of the sling lies somewhere here, much away from the forehead wound that you have created, so that the chance of suture granuloma or not granuloma is much less, and of course a frost suture. This is how these children look. Their head posture is immediately alleviated and their need to use frontalis is completely gone. They're very comfortable. Of course, there would be some amount of lag of thalamus which you need to take care of by lubricants. Now, about the surgery itself in adult patient or children who have who need a permanent or a near permanent surgery, there's a huge list of surgeries that you see here, but each one has to be used in a given patient very judiciously. If a patient has a ptosis of about 2 millimeter and levator action of 10 millimeter or so, then the first step that you do is phenylephrine test. 2.5% phenylephrine applied in the cul-de-sac and assess for lid elevation. Lid should elevate by about 2 millimeter following installation of phenylephrine. Some feel that irrespective of phenylephrine positivity, the correction is going to be good with mullerectomy, but it is known that if you have phenylephrine test positive or eplequinidine test positive, then the chance of you having a stable correction with mullerectomy is much better. Putterman described that about 8.5 millimeter of Muller's has to be excised to achieve the desired height, and add or deduct a millimeter for every 0.5 millimeter under or over correction. This is a standard thumb rule that we have, and we use a Putterman's mullerectomy clamp. If a patient has a negative phenylephrine test, you can opt to do Fastenal Savard procedure, which is a discredited procedure, but not. But I find that this is a very useful procedure and gives extremely predictable and stable results as long as you stick to indications of 2 millimeter ptosis and 10 millimeter levator action. These are your selection criteria. And for every millimeter of ptosis, you do 2 millimeter of resection. Now, how does this work? You have to have adequate tarsal height. At least 8 millimeter of vertical tarsal height preoperatively is mandatory, and you have to preserve at least 4 millimeter of residual tarsal height to avoid meibomian gland dysfunction and have a stable lid. So surgery is fairly simple. This is the patient that we are operating. We have everted the eyelid, marked the center in relationship to the pupillary axis, passed 3 sutures through the folded edge of the tarsus. This is to stabilize the tarsus as we do the surgery. And then the second set of sutures passes from the superior fornix, comes out just short of the lid margin. I'll show the significance of the second set of sutures when I go to that particular step. Lateral fornicial suture, you should avoid the palpebral lobe of the lacrimal gland. That's very important. Otherwise, you'll have brisk bleeding. So once you've passed these 2 set of sutures, you mark the exact area that you want to excise. And the marking is done in relationship to the central mark that you have created, exactly 4 millimeter. And then you taper your mark as you go temporally and nasally to match the contour of the eyelid. You cannot mark 4 millimeter, the extreme nasal or extreme temporal, and you have to taper it adequately so that the contour of the lid is not disturbed at all. This will minimize the incision line. I'm using a bipolar RF here. And then on top of that, I'm using a unipolar RF to minimize bleeding. Using these instruments makes the surgery very comfortable, and you can visualize exactly what you're cutting, avoiding any amount of abnormal dissection at the tissue planes, and you'll always maintain a good tissue plane. You'll visualize exactly what you're doing. Now we're going deeper into the tarsus. You see a gape that indicates that you've gone full thickness through the tarsus. So this is 4 millimeter of tarsus and tarsal conjunctiva. And the back of it would be 4 millimeter of palpebral conjunctiva as well. So you're actually excising 8 millimeter of posterior lamina, and that should be avoided in patients who have a tendency to entropion. So this is done under visualization. We are excising the tarsus, tarsal conjunctiva, and 4 millimeter of palpebral conjunctiva. We don't excise LPS at all in this procedure. Now, how do we suture it? We use a catgut suture, plain catgut suture, which has been soaked in saline ball for about 5-7 minutes so that it's become supple. The knot is exteriorized. Then you bring the needle in and then you run the suture. Run the suture continuously without exposing the suture itself. This is how the second set of suture works. It brings the pharyngeal conjunctiva right into view and the edge of the excised conjunctiva right into view so that you don't have to keep digging into the fornix for the posterior suturing. This is a totally buried suture, and if you fear that one of your loops may be exposed, then you can use a bandage contact lens so that the catgut does not abrade on the cornea. It's not a good idea to use glue to do this because glue generally tends to have undercorrection. If you have sutured it, then the chance of having a stable good correction is much better. So bring the suture out and exteriorize it so that you can cut the knots and pull the suture out after about 5 days. It's a very simple, straightforward 10 to 12 minute surgery with good hemostasis, and you can get good correction post-operatively. You can even see that the lid crease height has got normalized, which was earlier considered one of the challenges in this surgery. Now, this is one more patient where you see that the lid crease height has got completely normalized following Fastener Servet procedure. It works well in patients who have a good indication for it. When not to do Fastener Servet, whenever a patient has lash ptosis or a tendency to lash ptosis, you should not do it because then your chance of having post-operative entropion is going to be high because you're excising about 8 millimeter of the posterior lamina. Next, coming to levator surgery, the most common surgery that we do in levator would be levator resection, either by the conjunctival approach in patients who have a kind of smaller amount of ptosis, about 2 to 3 millimeter, and better levator action, say 7 or 8 millimeter, and already have a lid crease. But skin approach is good for patients who have much severe ptosis and much poorer levator action. How much to resect is always a question a novice surgeon asks. If you use the Beard's formula, it's very confusing. There are too many variables being ptosis, levator action, and the amount of resection itself. So it's complicated for a beginner. So I would advise Berkey's rule for a beginner surgeon. Now, with Berkey's rule, the first question is where to place the suture. You always place the suture under the Whitnell's ligament if you're doing a routine levator resection. If you place the suture above the Whitnell's ligament, it becomes supramaximal resection. If you place it through the Whitnell's ligament, then it becomes Whitnell's sling. Supramaximal resection and Whitnell's sling are done for patients who have severe ptosis with poor levator action as an alternative to tarsofrontal sling, and you should not place your suture above the Whitnell's or through the Whitnell's if you're doing a routine levator resection. The rules of the game are very simple. If your levator action is say 6, 7, 8 millimeter, that means it is good levator action, then you would correct that amount of ptosis exactly as you want it post-operatively. That means if you want 2 millimeter of limbal cover, you leave the lid exactly where you want it post-operatively because such lids hardly ever rise or fall post-operatively. If your levator action is worse, say 4 to 5 millimeter, then you have to overcorrect on the table because such lids drop post-operatively. If the levator action is better, say 10 millimeter, then you have to undercorrect on the table because such lids rise post-operatively. Most of your patients would fall into this category, 6 to 7 millimeter or 4 to 5 millimeter levator action. So you either fully correct or slightly overcorrect on the table. This will give you the best possible results. Surgery, again, I have simplified this video to suit the requirements of a beginner surgeon. You always mark the lid crease symmetrical to the contralateral eyelid because that's what the patient expects, symmetrization of not just the eyelid but also the lid crease. Then you make a skin superficial orbicularis incision with whichever instrument of your choice, but I would prefer monopolar RF electrode. Hold the skin up and do a suborbicularis dissection to expose the orbital septum. Change in color, you can see pink to yellow indicates that change in plane. Then that is where you landed on the anterior part of the septum. Now you do a suborbicularis dissection to expose the anterior surface of the tarsal plate. About 4 millimeter of the tarsus is exposed, not beyond that, because you don't need to really go anywhere beyond that. Once you're done that, the next step is to balloon the conjunctiva or create a plane of cleavage between conjunctiva molars and the levator aponeurosis using subconjunctival xylocaine. Any fluid can be used, but xylocaine with adrenaline can be used if you desire hemostasis and some amount of anesthesia as well, if you're doing this procedure under local anesthesia. Now then you pass a tractional suture with 4-0 silk through the levator aponeurosis, very superficial bite, 3 to 4 millimeter wide bites. I'll show you how this helps. This can be avoided by consummate surgeons, but for a beginner surgeon, this is very useful. Lift the levator up, it will create a slope, then you have to make that slope perpendicular. That means that your disinsertion is absolutely complete. You can see that perpendicularity has been achieved here. It means your disinsertion is absolutely complete. Once that is complete, then use a simple Johnson bud or a cotton tip applicator to peel the levator of conjunctiva molars muscle. So your posterior dissection is now over, but don't go too much superiorly because you don't want to disturb the phalangeal attachment. Then you come back to the anterior surface, open the orbital septum. You can see that legendary orbital fat popping out. It is beautifully yellow. Then you hold it with a Demers retractor and clean the anterior surface of the levator and the sheath without disturbing it. That's the Whitnell's ligament. You see it only to understand where exactly you want to pass your suture, not to disturb it. Cut the horns very gently, not to disturb the Whitnell's ligament. Then you're ready to pass the suture. As I mentioned, you have to always pass your sutures just under the Whitnell's ligament and tie the sutures with the adequate tightness to get the correction of your choice. So you don't have to keep shifting the position of the suture in every case. Every case you pass the suture right under the Whitnell's ligament, and the only thing that varies is the tightness of your suture. In some patients, you tie it tight. In some patients, you tie it adequate. In some patients, you hang back. So that actually gives you the best possible scope of correction without having to shift the sutures. 3 sutures, this is 6-0 proline that I'm using. Suture bite distance should be about 3 to 4 millimeter because you're passing the suture against the direction of the fibers of the muscle. So you have to have a good chunk of tissue between the suture arms, otherwise it will again cheese wire through. Once you pass these sutures, you have to tighten it to get the desired correction and then excise the stump of levator, whatever that is excess, and then finally form the lid crease using the stump of levator and the orbicularis to have a dynamic lid crease. And levator resection works well in majority of patients. Of course, there is a chance of late undercorrection, etc., but that can always be redone. About 10 to 20% of children who have undergone levator resection, when they become adults, will need a touch-up surgery. Now, in Whitnell's sling, where you pass the suture right through the Whitnell's ligament, you see that in primary position, the correction is excellent, but they tend to have excessive lid lag and lag of thalmus. In patients who have much severe ptosis, unilateral or bilateral, you do tarsofrontal sling. Ideal material is, there's no such thing called an ideal material. Some of the materials meet these requirements, especially silicone meets most of the requirements. It is non-biodegradable. It is not biointegrable, hence it is reversible. Whereas fasciolata is biointegrable and is not reversible or adjustable. So if you want a adjustable, reversible surgery, you would choose silicone, and the surgery itself is very, very simple and straightforward. Here we are using a 800 micron silicone sling for a child with ptosis. You can see that we are marking the Fox pentagon. These are epitarsal incisions about 8 to 12 millimeter apart, depending on the age of the child. These are medial and lateral suprabrow incisions in line with the medial and the lateral canthi respectively. And the central forehead incision is about 10 millimeter from the superior orbital margin, which is almost 8 to 10 millimeter in length. Use a spatula to guard the lid or a contact lens. Now make a very superficial incisions through the skin, stab incisions through these medial and lateral suprabrow incisions, and the frontal incision. Then, as in the previous sling that I showed, you create a prefrontal pocket. Then you're ready to pass the sling. The needle can be bent to adequate curvature. Chitra, just let me know if I'm overshooting time. I can cut it down anytime. From the central forehead incision, you pass it through the lateral supra-pro incision. From there, you come to the medial epitarsal incision, lateral epitarsal incision. From there, you come to the medial epitarsal incision, passing through the epitarsus, never through the tarsus. Still make sure that you haven't taken a bite through the tarsus by everting and checking. And then come through the tissues to the medial suprabro incision. This has to be suborbicularis under the septum, subbro, and acutely bend your wrist so that you exit through the proposed side. And finally, complete the pentagon by coming out through the frontalis muscle. The gap between the two arms should be about 4 millimeter here. Now you pass the sling through the sleeve, which is 1300 micron outer diameter. It fits very snugly. Then you release the sleeve from the artery clamp. Then you tighten the sling to the adequate tightness. Assess the height that you're very sure of, and then you lock the sleeve using a 60 Prolene suture. I use a monofilament Prolene to lock the sleeve. This makes the procedure more reliable. The sleeve won't slip through. Once you lock the sleeve, you cut the sling and bury it under the prefrontal pocket. About 8 to 10 millimeter extra sling is left for future adjustments. This sling can be adjusted any time during the lifetime of the patient. It remains as virgin as you put it. Silicone is highly biocompatible and non-biodegradable, so you can open it and adjust any time if you want a better correction over a period of time. Then simple sutures and then a frost suture. So this is a patient who has undergone a unilateral tarsofrontal sling. You can see that the child doesn't have to use frontalis so much and remains well corrected. This is a young adult who has undergone a unilateral tarsofrontal sling with silicone, remains well corrected. In special situations, I wouldn't go into the details. Synkinetic ptosis, elevator undercorrection, and blepharophimosis. These are advanced procedures. In the involutional ptosis, in a patient who has aponeurosis, disinsertion, or dehiscence, you have a separate procedure. This is a surgery which is, in fact, becoming quite common these days. I think this video is not playing. All right, so I will just show you levator plication, which somebody was asking a question about. Levator plication is a very, very straightforward and an easy surgery. Lid crease incision, everything, initial parts are all the same. Then you identify that there is indeed dehiscence and not disinsertion. Create enough space for you to pass the sutures. For every millimeter of ptosis, you have to plicate 6 millimeter. So you mark exactly the amount of plication that you have desired. I mark these two points on the center and the medial and the lateral side. Then I use a 60 Prolene suture, 4 millimeter from the upper edge of the tarsus or the middle of the tarsus, which is passed within the tarsus, making sure that you haven't passed it full thickness. Then take a bite at the upper edge of the tarsus so that the plicated levator lies at the upper edge of the tarsus and not comes through the anterior surface of the tarsus to avoid doming. Then this double arm suture is passed through the desired point. So you're only passing this suture through the levator palpebrae superioris and coming out through the desired point. Then all you need to do is tie the sutures. That is the end of surgery. So plication is a very simple surgery, as Kasturi pointed out, and then give you very, very predictable results, especially if the patient has a good levator action and mild ptosis. You can correct it dynamically on the table. And this one patient who has undergone plication in the left eye with good results. One more patient with plication. So finally, complications have all been covered, but most important in ptosis surgery is to assess, set the goal for a given patient. Perfection is an unreasonable goal in ptosis surgery, unlike refractive surgery or cataract surgery. Explain until the patient understands and the parents also understand. Always follow a thumb rule. Anticipate and prevent complications. Customize your surgery. And if at all you find that there is unexpected under or overcorrection, don't wait for the tincture of time. Always adjust. And you have already counseled that the need for adjustment is real, at least in 10% of patients. And use that to adjust early so that you get expected results. Thank you so much. Chitra, you're not heard. Muted.
I'm muted.
It was a wonderful talk, Dr. Santosh. I could say it any number of times. I'm going to ask a very basic question. There are patients who come for refractive surgery and they may have coexistent ptosis.
Okay.
So would you operate first? And do you think ptosis correction can have an any kind of impact on the keratometry?
Yeah. So it's known that if a patient has more than 2 mm of ptosis, that can impact your keratometry and also the topography as well. So if you if a patient has significant amount of ptosis which is coming to the upper edge of the pupil, etc., that can also cause diffraction effect. So, and also post-operatively, you tend to use steroids. And if a patient has acquired ptosis of any etiology, use of topical steroids causes some amount of fat infiltration in the levator and the ptosis may become worse. So it is better that if a patient has significant amount of ptosis, you operate the ptosis first, wait for about 6 to 8 weeks, even 12 weeks for that matter, for the cornea to stabilize, and then do refractive surgery.
Thank you. Yes, on to you, Vidya.
On similar lines, sir, if a patient has got aponeurotic ptosis and cataract, the common question, what to prioritize first, whether ptosis correction or cataract?
Well,
And
if
what
it
will
is
be the preferred
significant, if you want to use a multifocal lens or a toric lens, and if the patient has ptosis covering the pupil, there is no point doing cataract surgery first, isn't it? So if a patient has only a cosmetic issue with ptosis, then better that you do cataract surgery first so that he's able to appreciate the beauty that you're given after ptosis surgery. Otherwise, if a patient has functional ptosis, it's best to correct ptosis first and then do cataract surgery.
And one
Suri
more
does
thing
both.
is,
Probably she can answer.
yes. One more thing is addressing the asymmetrical eyelids, sir. That's a common consideration following ptosis surgery. And how do you approach if a patient has got this common complication? What strategies would you follow?
Asymmetric lid in the sense under correction, is it?
Under correction or over correction? When do you
Right.
recorrect? And yes, sir.
Right. So under correction is more common in congenital ptosis and over correction is more common in acquired ptosis. Now, in congenital ptosis, you tend to over correct on the table if a patient tends to have little poorer levator action. So that will prevent under correction in congenital ptosis. Some amount of over correction is desirable in congenital ptosis, whereas in acquired ptosis, you tend to under correct a bit on the table so that the patient has better correction post-operatively. So this is a thumb rule, but obviously you have to customize it. And I would always see the patient at about 6 or 7 day post-operatively once the edema has resolved. And I already would have counseled the patient that there would be a need for post-operative adjustment in at least 1 in 10 patients. And if a patient has surprise under or overcorrection, I deal with it absolutely under topical anesthesia, unless the patient is a child. I have never had to give a block for adjustment. Take the patient to the OT, of course, drape and all that, but only topical anesthesia. I don't infiltrate at all. So your correction is absolutely perfect. You tie the suture with enough tightness. There is no infiltration. There is no frontal block. There is no edema. So you tend to have a much better outcome if you adjust it post-operatively at about 6 or 7 days, if at all you have an under or over correction.
Yes, sir. Thank you so much.
Vidya, can I just ask one question?
Yes,
Sir,
please.
sir,
Vidya has difficult questions.
no, when you're using ethibond for congenital ptosis in the early phase. I have had issues where when you want to redo that, it forms a fibrous track all around that ethibond, and it's very difficult to dissect it and take it out. Is there any particular reason why you're choosing ethibond and not silicone rod itself? Why is it that we cannot? Is there
You can
anything
use silicone, but it is more extensive dissection. Ethibond is a tract and it is easy. You know, what you can do is you reverse the Bardpaka knife, you palpate the tract, and with one single sub-millimeter snip, you can simply cut the tract.
and
Wherever you
leave
want
the
to cut it.
ethibond inside?
Yeah, you can leave the ethibond inside. It's for life. If you cannot take it out, I would make an attempt to take it out in about 70-80% of patients. I'm successful in taking out without any trauma to the frontalis muscle. The moment I expect that my dissection is going to be more extensive, I simply cut off the tract and there is absolutely no problem.
Thank you.
Thank you.
We shall go on to our next speaker, Dr. Bhagwati Badbekar, and who is from the Department of Ophthalmology, Sri Manakula Vinayagar Medical College Hospital. And the topic is going to be a rational approach to managing blind eyes. Very important talk. On to you, Dr. Bhagwati.
Yeah, am I audible now?
Yes, yes.
Yeah, I'll just share my screen. I like to thank Chitra Madam and Dr. Vidya for giving me this opportunity. Just a minute. Yeah. So blind eye is the one with the visual acuity of counting finger or the worse, and there is no probability of recovering the vision in such a patient. And these patients have already exhausted with ongoing treatment for recovering the vision. Hence, it is very important to handle these patients with care. So for the purpose of understanding, I will like to divide according to the cosmesis and the pain into the 4 categories. The first category is blind eye with no pain and normal cosmetic appearance, where the vision is the main concern. The second is blind eye with a pain and normal cosmetic appearance, where the eye pain is the concern. Blind eye with pain and abnormal cosmetic appearance, where both eye pain and cosmesis is a concern, and blind eye with no pain and abnormal cosmetic appearance, where cosmesis is mainly the concern. So this is a blind eye first category, blind eye with no pain and normal cosmetic appearance. Here you need to take a detailed history, do detailed physical examination and the relevant investigations to determine what is the cause of the blindness. Then you need to make sure that the patient gets the treatment for the condition which has led to the blindness. Explain the poor visual prognosis for the blind eye. Explain the risk of blindness in the other eye so that the patient is able to be more compliant with the treatment and give protective glasses and tell him the importance of the follow-up. This is another category where blind eye with pain and normal cosmetic appearance. So in all these eyes, you have to do a thorough clinical examination, which includes the intraocular pressure and fluorescent staining and slit lamp examination for cells flare and iris neovascularization. If the pain in the eye is due to the increased IOP, then you can go ahead with pressure lowering drops and topical steroids and cycloplegic drops. And if it is due to corneal surface problems, you can give lubricating drops, therapeutic contact lenses, topical steroids. If it is due to inflammation or like uveitis, you can give topical steroids and cycloplegic drops. If there is no improvement and if the patient is having the high IOP and if patient is willing for the intervention, then you can go for cyclodestructive procedures such as cyclophotocoagulation with diode laser. Or if patient is not willing for cyclodestructive procedure, then you can give a retrobulbar injection of ethanol 2 ml, 96%. But a better alternative is chlorpromazine, which has a longer efficacy, that is around 1 year will be the painless period, and also efficacy is good, that is 80 to 85%. Then you can give for exacerbations, you can give NSAIDs and gabapentinoids. If the patient has the corneal surface problems, then you can give a conjunctival, you can do a conjunctival advancement flap such as Gunderson flaps or the amniotic membrane graft. These actually work by preventing the proteolytic enzymes in the tears for coming in contact with the corneal surface and thus preventing the corneal surface. This will also make the cornea surface vascularized and this will reduce the sensations of the cornea. So if the patient in the later stage wants some shell, we can put it over for the cosmetic purposes. If patient is not willing for this, then you can do anterior stromal puncture followed by the bandage contact lens. And for exacerbations of the pain, you can add systemic medications and retrobulbar injection. If the pain is due to inflammation such as uveitis, now the recent proposed treatment is injection triamcinolone intravitreal in the single dose of 12.5 milligrams per 0.3 ml. If patient is not willing for this, then we can give a retrobulbar injection. If none of this works, then the last resort is evisceration or enucleation. But in a clinical scenario, we should discuss evisceration and enucleation even when we are putting the patient on the medical treatment so that the patient is ready emotionally and psychologically for this procedure. This is a patient with a painful blind eye due to glaucoma, end-stage glaucoma, and his IOP after the maximum IOP lowering medications was 30 millimeters of the HG. His pain was not responding to the topical treatment and the cyclodestructive procedure, and then went ahead with evisceration with implant in this patient. This is another category of blind eye, where the blind eye with pain and abnormal cosmesis, where both cosmesis as well as the pain is a concern. In such a case, you should discuss with the patient what he is concerned about, pain or cosmesis. If he wants only the pain relief, then you can go ahead with the previous treatment shown in the previous slides. And if the patient is concerned about both pain and cosmesis, then you can decide for evisceration or enucleation even at the earlier stage. Now, this is the fourth category, that is blind eye with no pain and abnormal cosmesis. Now, the abnormal cosmesis in this case can be due to corneal opacity, or it can be due to a thicical eye, or it can be due to a staphylomatous eye. Now, if patient have a blind eye with corneal opacity and a normal sized globe, cornea is smooth, then you can go for a cosmetic contact lens trial. If the patient tolerates well, then you can continue the cosmetic contact lens. If patient does not tolerate, you can think of doing the corneal tattooing. If the cornea surface is irregular or the anterior staphyloma is present, you can go with evisceration or enucleation with the implant. In case on B scan there is a intraocular malignancy, you can plan for enucleation with the implant. Now, this is a patient with having the anterior staphyloma. In this condition, we did evisceration with the implant. But if the anterior staphyloma is covering the most of the sclera, then you can also think about doing enucleation with implant in such cases. Now, this is a blind eye with no pain, but a thicical eye. So in this, we can give a shell trial to these patients. So if the patient tolerates these shells, then you can continue with the shell. If the patient, if it is not matching with the other eye shell, then you can send him to the ocularist to get the custom fit prosthesis. In case the patient does not tolerate these shell, then we can go ahead with enucleation with implant. Now, this is a patient who is having the thicical right eye. You can see the conjunctivalization of cornea there. So we gave her the shell trial and she was able to tolerate the shell and she was quite happy with the shell. And so we asked her to continue it. This is another patient who is having the right eye thicical. You can see the cornea is clear. So when we gave shell to this patient, he was not able to tolerate that shell. And then we did a enucleation with implant in this patient. You can see the residual ptosis here after enucleation with implant, which was corrected later with frontalis sling. The choice of the surgery, whether to do enucleation or to do evisceration, depends upon what is the ocular disease, and it also depends upon the surgeon's preference and patient's preference. So intraocular absolute indication for the enucleation is any intraocular malignancy or a badly traumatized eye where repair is not possible. So in these cases, if we do enucleation, there's no fear of sympathetic ophthalmia. Now, evisceration is a simple surgery. It is less complex and it gives a very good implant motility and less of bleeding is there. Hence, most of the oculoplastic surgeons prefers evisceration with implant in all the other cases. So evisceration with implant can be done in staphylomatous eye or it can be done in endophthalmitis. But for panophthalmitis, there are different school of thoughts. Like first, some clinicians think that they do evisceration in case of panophthalmitis because it gives a very good implant motility and it is an easy procedure. But if you are doing evisceration in case of panophthalmitis, it is good to give the IV antibiotics and anti-inflammatory to control the infection and the inflammation before doing surgery. So this is a lady where we did evisceration with implant in panophthalmitis after giving the IV antibiotics and anti-inflammatory. The other school thinks that we should not do evisceration as it may transfer the infection from to the brain through the meninges, or there may be residual infection which may be left in the sclera. Evisceration we should also do in expulsive hemorrhage. Now, intraocular malignancy is an absolute contraindication for evisceration. We should also avoid evisceration in few cases, such as severe trauma, where the uveal tissue is going to be adherent and it is very difficult to clear the uveal tissue from the sclera, where the prior VR surgeries has been done, like cryotherapy or laser therapy has been given. So again, the clearing of the uvea is very difficult in such cases. In unknown etiology, when eye is thicical and etiology is not known, especially in children and in the elderly people, we should avoid doing evisceration. In the severe thicical eye, we should avoid doing evisceration because we won't be able to put an optimum size prosthesis implant in such cases. Whereas in mildly thicical eyes, we can do evisceration where we can give the relaxing cuts, or we can do sclerotomy for mildly thicical eyes. If there is extensive calcification, then there is a chances of having the occult tumor. So it is better to avoid evisceration in such cases. Now, we should be very clear about the patient expectations before evisceration or enucleation, whether patient wants cosmesis or whether the patient wants only the pain relief. We should go ahead with a B scan to rule out the malignancies. If UBM is available, you should do UBM also, which will help us not to miss the anterior segment tumors. And CT scan and MRI may also be helpful in thicical eyes because the B scan is maybe difficult to perform B scan in such eyes. We should send the enucleated eyeball for histopathology as well as the eviscerated contents, which we should send for histopathology. Now, these are the different implant. This is a non-integrated implant, that is silicone and PMMA. This is semi-integrated implant, and this one is integrated implant, hydroxyapatite and porous polyethylene. So this is integrated to the orbital tissues by the growth of the fibrovascular tissues. And this can also be integrated with the prosthesis with the help of pegging. This one is a dermis fat graft, which is a biointegrated implant. So which implant we should put? So in most of the cases, the implant of choice is PMMA or silicone, particularly if we are doing enucleation. In case of a child, so we should use PMMA or silicone, and also in the adult where there is intraocular malignancy, we should do the PMMA or the silicone implant in such cases, because these patients may require radiotherapy later if there is any recurrence. And these implants, they are resistant to the radiotherapy. And it is easy to identify the recurrence with these implants, that is PMMA and silicone.
1 minute left.
These implants can be exchanged because these are not integrated with the orbital tissues. These are also very much cost effective. So in evisceration, we are going to put it in the scleral shell, whereas in after enucleation, we are putting it in the intraconal space. Now, if you are putting a smaller implant, there may be a superior sulcus defect like this, and the prosthetic motility may not be very good. If you use a larger implant, there are the chances of implant extrusion or erosion, and you may not be able to put a prosthesis in the front. So hence, we need to put an optimum size implant. So our globe is 7 cc, and we need, when we do a enucleation, there may be deficit of this 7 cc. So we have to compensate for this 7 cc, which is done by 60 to 70% by the implant and 30 to 40% by the prosthesis. So this 4.5 cc corresponds to 20 millimeter of the implant. And 20 millimeter of implant is actually the ideal size for the adult. And if we are wrapping it with a sclera, then you need to subtract the 2 millimeters. That is, you can put a 18 millimeter implant and wrap it with the sclera. That makes total of the 20 millimeter. If you are doing evisceration, then we have to use a small size implant, because for evisceration, we are putting it in the scleral shell, whereas in enucleation, we are putting it in the posterior tenons space. So for evisceration, 16 millimeter implant is ideal and also safer, because we can suture the sclera without tension. And this will also provide us some space to keep the prosthesis in the front. So these are the few surgical tips for enucleation. That is, do peritomy very close to the limbus so that most of the conjunctiva is saved. Avoid buttonholing, use blunt scissors. And when you are putting a tagging suture, silk suture, then keep at least 1 millimeter distance from the insertion and pass another suture, vicryl suture around 6 millimeter away from the first suture and cut between the two muscles and leave some stump on the either side so that the suture does not slip away. And then prolapse the eyeball out of the eye speculum so that the optic nerve is stretched, and that will help us to get a long stump of the optic nerve while cutting. Try to take a long stump of the optic nerve without causing damage to the vessels there and the nerves coming through the superior orbital fissure so that the good implant motility is maintained after the procedure. And put the conformer in the end. For evisceration, the few surgical tips: do a peritomy, try to save the conjunctiva, and when you remove the uveal tissue, try to take in a single bolus, try to avoid taking in the fragments, and in the end, you can apply the absolute alcohol to destroy the whatever small fragments are left, and always send the tissue for the histopathology. Thank you very much.
Thank you, Dr. Bhagwati. That was such a thorough, detailed talk. Vidya, can you just take one question before we go on to our next speaker?
Yes, Bhagwati, that was an excellent presentation. And you did mention everything, actually. You said it all. But I just have one question. How you mentioned about doing evisceration in a mildly thysical eyes. So how do you do that? What is your technique of relaxing incisions? How do you do that exactly?
Actually, there are multiple techniques described in the literature. So one of the simple technique is just to give the 4 relaxing incision in between the rectus muscle. You can give oblique incisions between the rectus muscles, and if you want, this will expand the globe equatorially, and you will be able to put a larger implant. And you can also give a relaxing incision in a circumferential fashion around the optic nerve. And other technique, recent technique described is a 4-petal technique, which you can cut the 4 petal lights from the sclera, avoiding the rectus muscles, and then suture those 4 petals. And this will help you to accommodate a larger implant.
Excellent. Okay. Right.
Thank you.
Thank you.
We have Dr. Ganesh. Very sorry, Dr. Ganesh, we missed you out. Calling you immediately after Dr. Santosh. Can we hear your presentation?
Okay. I'm sharing my screen right now, madam.
Yes, doctor.
So this is the maximum resolution that I can get. Is this okay?
Yes, this is okay. Absolutely.
Right. Okay, so my topic for today will be actually strategies for a successful lacrimal surgery. But I think I know everyone has already talked everything about it. So I don't know if there's anything left to talk about it. But I will look at it in another way. First, at the outset, I would like to thank Team Eye Foundation for giving me this platform to share my experience. And also sincere lot of credits to my mentor, Dr. Mohammed Jawad Ali, and also Dr. Jai Gayatri, who has been gracious enough to submit one of her videos for my usage. More than strategies to perform a successful DCR, I think a strategy to film a DCR successfully is even more difficult. So I think we can make out when we see her video later on. Right, so if you see the strategy-wise, going to the topic, it's simple. A satisfied customer is the best strategy of any business. If you replace customer with patient and business with treatment, that is it. So there's nothing left to talk about it. At the end of the day, the patient should be satisfied. That is it. It doesn't matter what technique you use, what hi-fi instruments you use, or what you do. If the patient is not happy about it, all of it really goes to a waste. So that is why it is more difficult in our profession to not only satisfy the customer, to also bring out the best. So coming to a successful DCR, what would be the goals of a successful DCR? There are mainly 3 reasons. One would be a large osteotomy to facilitate the anatomical drainage. You want a mucosal lined nasolacrimal anastomosis to ensure continuous drainage of the tears. And then you need a low resistance patent drainage system, which accounts for the physiological patency. So there may be many times where you may have an anatomical patency when you have a large osteotomy and you have this nasolacrimal anastomosis. But if there is no physiological drainage, patient will still complain of epiphora. So that is another thing that we need to tackle about. So these are the new strategies. I mean, basically, it's not strategies. It's just revisiting our basic and core concepts to understand what causes this, which will help us make better and satisfactory outcomes. Okay, so because in the screen show, I'm not able to share this video. I'll just
So would you like to play it at the end, sir? Like
okay, I think that also makes sense. But can you see this?
no.
Okay,
Because
so
this will be difficult going back and forth.
So I think if there's time, then yeah, we'll do it later. So basically, my topic would be, like I said, just to revisit some core concepts in the following topics, which is where most of us have difficulties, especially for the beginners. With regard to the preparation, I mean, much has already been talked about how to select the patient and all other details as to where the skin incision is going to be, what I'm going to do for hemostasis, the size of the osteotomy, how to manage the flaps, and the use of adjuvants. So this is just a refresher sort of thing. I'll just rush through this. So coming to the preparation, I think from the novice's point of view or beginner's point of view, this would be the most important slide of this. It's not about the techniques. It's not about thing. It's about how prepared you are to face this. Because I think most of the oculoplastic people over here are institutional based over here. I am telling this purely from a perspective of someone who freelances and who operates in multiple setups. So where the setup is different in each place, which means you will have to adapt yourself. So just like you said about patient selection, for me, the hospital selection and OT selection also makes a big sort of difference. So there is no bravado in saying that I will, however complicated the cases, I will do it in local anesthesia. I would refuse to use stents or something. The basic thing is we should throw our ego out and we should be prepared to accept whatever and make it beneficial for both the patient and us. So with regard to anesthesia, like I said, most of us prefer the local anesthesia, and understandably so, given the low amount of risks and everything. But for patients who are very apprehensive or patients who are really having this white coat hypertension sort of syndrome and all that, you find that they get even more tensed up and they get even more agitated, especially when you use preoperative oxymetazoline and all that. The hypertensive thing is shooting up so much that itself adds on to the barrier. And remember, whenever a patient is jittery, the entire surgery becomes same because it passes on to the staff nurse, it passes on to you, the time gets prolonged, and then everything gets sort of thing. So these are the things where you should actually concentrate to actually get a better sort of outcome. Similarly, adequate lighting. There are many places where I operate where they don't have a regular lighting system. I have to use with a head loop with the light and all those kind of things. So the angulation is different. And staff, this is a very important thing. It's very good if you would know the level of your staff, because unlike cataract surgery or other surgeries where they just do passive assisting, this is something where they need active assisting. They need to be anticipating what is going to happen in this step and where are the bleeders coming from, what to rush, rather than waiting for you to call out and hand an instrument and everything. So depending upon the staff, you can take liberties. So like what I would say is for novices, if you feel that the staff is not experienced and all that, you can probably take a larger incisions to get better view rather than expect them to do that for you. So small things which will be, like I said, case-based sort of thing. Instrumentation, make sure that you have the entire set of instruments, preferably with a spare, because you never know what will happen and you don't want to be doing cases with a half support system and have to managing without this instrument or something like that. I would say powerful suction, judicious cautery, and a staff with good lighting. This is more than sufficient to ensure a successful DCR, whatever the complications are. The risk factors, like what people are talking about, patients with chronic dacryocystitis, what all had recurrent acute dacryocystitis or other nasal factors, those are things which you cannot control. And like you said, you cannot select the patients. They come to you like that. So you have to offer them treatment, whatever comorbidities they have. So it's how you adjust with it. That's what makes up the better outcomes. So coming to the incision, I think much has already talked about it. The most commonly used incisions are the straight incision and the curvilinear tear trough incision. So basically, you would see that the curvilinear incision is a little more medial, whereas the straight incision is a little more lateral or towards nasally. The reason is straight incision on the lateral part of the nose, that there is thicker skin, so there is less chance of contracture, so that gives good stability. The flip side is accessing the sac and the canalicular region may be a little more difficult because it is further away from the canalicular opening. The curvilinear incision is a little more closer, and the reason it is curvilinear is because of the nasal convexity of the angular vessels. Again, the curvilinear incision, if extended above the medial canthus, can result in bowstring type of scars or an cicatrical epicanthal fold, which may add to the dyscosmosis. Now, most of us will also see cases where there have been subacute or just resolved acute dacrosis iritis, or ones which present with a lacrimal fistula. So the initial thing would be probably is there's already an opening there. Why not I just open up that? That will make sense rather than inducing another scar. Actually, that is the worst thing to do. You should look for a site which is away from the inflammation, which will give you a better sort of thing. If you try to open up at this spot, you're going to land up with lots of inflammation, cheese wiring, inflammation, and bleeding. So it is always best to go a little more medial to where the fistula is. Another thing is when you have a mucocele, it is best to decompress the sac before to avoid inadvertent puncture of it, so that you can get your incision as close as possible to the anterior lacrimal crest. Coming to the anatomy, I think, okay, this is not visible because it's supposed to be hidden. Okay, right. So I'll just probably move this away. Yes. So coming to the anatomy, what are the points, relevant points that you would need to know is the anterior lacrimal crest. Are you able to see my cursor on the screen?
Yes, sir.
Okay, fine. So this is the anterior lacrimal crest, and this would be your first identification point at the initiation once you've done the blunt dissection and retracted the angular vessels. So this is the end point, the start point of where your, it's the superior point of where your osteotomy should end. So once you identify the anterior lacrimal crest, then you can find the cleavage plane in the lacrimal fossa to separate the sac fossa. So that is the importance of the lacrimal crest. Next, you will see something over here which looks like a partial suture line, which is actually a misnomer. It is basically a vascular groove called the sutura nota, which basically contains emissary vessel veins from the infraorbital branches. So this is a notorious site for bleeders. So if you know this, you can expect to have bleeders here. You can cauterize it and you can expect a less blood surgery. Other than that, you would also have another few perforators here and there, which will be subperiosteal, which can also be managed with a gentle cautery. Next, there's a medial canthal tendon, actually, which is not represented over here. The medial canthal tendon has one limb which is attached to the anterior superior part of the anterior lacrimal crest. Why this holds importance is in DCT surgeries, we actually disinsert the medial canthal tendon so that we can remove the sac in toto. Whereas in DCR, some surgeons prefer to leave it alone, whereas some people disinsert it again. So my tip would be probably is if you're having inexperienced staff or who's not able to retract properly, you find the views and everything, there you can probably disinsert it, because once you disinsert it, you'll get a nice view of the sac coming off from the lacrimal fossa. But if you can preserve it, it's well and good, because it plays a part in the lacrimal pump mechanism. I'll just talk about that a little later. Fine. So then you have a few suture lines. This is the lacrimo-maxillary suture line. which is the junction of the maxillary bone and the lacrimal bone. So this would ideally be your thinnest point and weakest point where you would probably initiate your osteotomy to begin with. Then you also have what is over here is the posterior lacrimal crest. So this will be the end point of your reflection. Your osteotomy should cover this entire area. This is the lacrimal sac fossa, which encompasses from the anterior to the posterior lacrimal crest, and you need to do a dissection up to here. The more posterior the lacrimomaxillary suture is towards the posterior crest, it means it is predominantly maxillary bone, which means you're going to have a tough time ahead, thicker bone. So you need to use more of the higher sized rongers. Whereas if this is more towards the anterior side, then you'll have more of lacrimal bone, which would be easy to remove and peel off. Right. So other than that, there are a few other landmarks, which is basically for the novices who get very enthusiastic and just keep going on and on and on. So once you go behind the posterior lacrimal crest, if you see, you just go around here. This is the lacrimoethmoidal suture line. So if once this is breached and everything, you would be entering into the orbit directly, and you will start having fat prolapse and all other issues related to that. So it is best to stay clear at around the posterior lacrimal crest. Similarly, for those who like to keep on going superiorly, this marks the frontoethmoidal suture, which actually corresponds to around the level of the cribriform plate. So only if you go above this, there is a chance of you causing a CSF leak. Otherwise, if you stay well within this, the chances of developing that is very, very less. So these are the important sort of things that you need to know. And like I said, this is the size of the osteotomy that we would require. So now the question would come is, the inferior meatus is not so large. This is around a 12 by 18 mm osteotomy. Why do we need such a large osteotomy? Is it enough for the tears? Compared to the canalicular size, this seems very large. So why do we need a large osteotomy? For two reasons. One, the larger the osteotomy is, the easier for us to prepare the flaps. We can get larger and better flaps. Two, the bone also will undergo some remodulation, which means your osteum size will shrink at 3 months, 6 months. If you see, the size of this would shrink by more than 40 to 60%. Okay. Okay, so this is what I was talking to you about, the lacrimal pump. So if you see the orbicularis, when we close our eyes, it has a mechanism where it exerts positive hydraulic pressures, which pushes the tears into the canaliculi. And from there, it goes into the thing. And also some muscles get attached to the lacrimal fascia and the anterior lacrimal crest and the medial papillary ligament. So if you disturb this, there is a chance that this pumping mechanism can get affected. Of course, this would not matter if it's a case of atonic sac. So there you would be freely liberal to disinsert and you need not even reinsert it. But for other conditions, it's best to reattach wherever possible. I think this will give you a better understanding of the lacrimal pump, what I was talking about. So basically, if you see, it is called as a 3-compartment model. So you see the tear lake in the eyes. At a lower level, intermediate level is the lacrimal sac, which is connected through the canalicular system here. And from the lacrimal sac into the nasal cavity through the inferior meatus. So if you can see, it is all at a descending level of gravity, which gradually helps the tears to drain down. Plus the canalicular system over here, which has the suction or hydraulic pressures, which draws the tears into the canaliculus over here. And over here, you have the valve of Hasner, which does the same, which prevents air from entering in the nasal cavity to enter into the nasolacrimal duct and vice versa. So these two function as the valvular mechanisms for regulating the direction and stream of tears flow. So what happens in a DCR surgery where the osteotomy is inadequate or the canalization is incomplete? So technically what happens over here is, if this is the inferior meatus opening, in DCR you're making an opening in the middle meatus. So generally it is going to be a little higher up to this. So when it goes a little higher up, obviously the tear flow will not be as good as it was while descending down. So that is why we need to ensure that the medial canthal tendon is preserved as far as possible. And in a good DCA, if you see, you would actually be converting the 3 compartment into a 2 compartment, which means both the lacrimal sac and the nasal space is fused together as 1 compartment so that it facilitates a free flow. This is what we mean by physiological patency and not just anatomical patency. In these kind of patients, if you see, the syringing will be patent. But when you do the fluorescent dye disappearance, you will find that it is still prolonged or delayed. It will not be
1 minute left.
Yes. Right. So once you've done the osteotomy, and as I've told before, we've already opened up the flaps and sort of thing. So what I would suggest over here is, if you don't have a good lacrimal flap, always make use of the nasal mucosal flap in accordingly. If you have a very poor or short anterior flap over here, make a larger anterior flap in the nasal side to compensate. Or if you have a very good large posterior flap over here, you can always trim it and again attach it to the posterior flap. So these are all things which you would start doing down the line, not as an initial thing, but once you start looking for how to best manage the situation. Okay, so I think these are all already covered. So these are all just steps which I don't want to take up much time. Yes, so whenever you do the flap anastomosis, you make sure that if at all you're using any tubes or anything, it is passing right under the flap, so you know that doesn't get tethered within the flap. And also the flap anastomosis has to be taut. It should not be sagging. So if there is any sagging or something, you can either use anchoring sutures or you can trim off the extra mucosal so that it's made taut. Another thing is preferably aim for an end-to-end anastomosis, no overlapping. If at all there is overlapping, we would prefer the nasal mucosal flap to be over rather than under, because it will have a tendency to proliferate towards the common canacular opening. With regard to stents, some overzealous people who may tug on it inadvertently may also cause punctal cheese wiring. So that is another thing to be wary of when you're using stents. With regard to stents, I prefer to use them usually in cases where there is intrasacral synechiae or pericanalicular adhesions or distal canalicular stenosis blocks, and those kind of cases where you would expect high chances of failure. I would not do it routinely for all cases. And I keep them for usually 4 weeks, after which they are removed. I do not keep them longer than 4 weeks. Again, that is another video which was thing, right? Right. So do I have time to play the video of Dr. Jay Gayatri's?
No, I don't think so. Doctor, sorry, so sorry. There's one more speaker and it's
Okay.
9.
Actually, because there is a very good video where you can actually make out things. Okay,
How?
probably if it's possible after the next speaker then.
Sure. Vidya,
Yes, ma'am.
shall we go on to the last speaker?
Yes, ma'am.
Okay.
Yeah.
So we have now we always keep the best for the last, don't we? So we have Ritwija Thomas, who's going to be talking on mitigating and addressing complications in socket surgeries. And she's a young oculoplasty surgeon practicing in her own center, the Vision Eye Center at New Delhi. On to you.
Thank you so much, ma'am, for that introduction and for having me on this fine webinar with so many great speakers. So what I'll be talking about is basically socket complications and how to manage issues in the socket. But it's important to know that a healthy socket is well epithelialized, has a satisfactory central implant, and has adequate volume and phonics in order to give a cosmesis when you put in a customized prosthesis. The eyelids also have to be addressed, and here you can see an image wherein there is a slight ptosis without the prosthesis, and with this can be sort of mitigated once the prosthesis is in place. So this is how a patient with an ideal implant looks. And moreover, they should have good implant motility as well, especially in patients who've undergone evisceration. They should be evisceration with a ball implant. They should be able to have at least 30% motility after the surgery, along with good blinking and a fairly good motility such as this. The types of prosthesis I won't go into, but these are the basic types. Now, troubleshooting comes from a very young age, that is in congenital anophthalmic sockets, wherein there is a shrunken orbit, there are minified eyelids, and there is a deficient conjunctiva. So there is also a hemifacial overall retardation of development. Now, here you do need to do a good workup with some amount of imaging, along with a multidisciplinary approach, which is mainly the work of the ocularist and the oculoplastic surgeon. So we address the bony hypoplasia and the soft tissue hypoplasia, along with any cysts that may come up on clinical examination or on imaging. Now, there are various ways to address volume expansion, but the main way is serial conformers. So there are various shapes and sizes that each ocularist has developed to help with expanding these orbits. But with time, as the child grows, monthly, 3 monthly, 6 monthly with age, we tend to change these conformers in order to help develop the bony as well as soft tissue parts. Now, coming to adults, the basic thing is right after you do the surgery, you can have postoperative inflammation like this if the patient has not taken oral steroids. So it's important to make sure that the patient is on a good complete dosage of oral steroids after the surgery, along with adequate antibiotic cover. You can have some amount of dryness, which is combated by lubricants. There can be discharge and irritation, especially if there are any issues with the implant. You can have enophthalmos after the surgery. Enophthalmos, when there is a no primary implant, then you have to put a secondary implant or a dermis fat graft, which I'll be coming to. If there is already an implant, then you do a dermis fat graft or put in additional implants such as subperiosteal wedge implants. If there is an associated traumatic floor fracture, that has to be repaired as well. If there is a superior sulcus deformity, that could be again due to decreased orbital volume or sagging of the lower lid. So in this case, you do need to sort of get the prosthesis adjusted. Along with that, you can do a volume augmentation, and you can do the lower lid tightening to prevent sagging of the prosthesis. You can also actually inject fillers into the orbit. Now, implant exposure is a very big issue wherein the implant sort of starts extruding from the cavity. This can be because of infections, or in immediate cases, if the implant is too large. Later on, it could be because of some amount of fibrosis long term. It can also result when there is a unsatisfactory kind of implant, such as this is quite common in the hydroxyapatite implants. Now, what can you do for this? If it is a very early situation, you can do some resuturing or put a patch graft. But if it's late, you would require a secondary implant or any other additional modalities such as a mucous membrane graft, etc., depending on what the situation is and how much tissue has been lost. Inferior phonic shelving is very easily picked up because the patient complains that the implant is not sitting well and falling off all the time, and they have an inability to retain the prosthesis. So this could be either because of lack of proper phonics, or because the eyelid is turned outward, or even in case of severe enophthalmos and cicatrization, such as in this individual who had a traumatic contracture of the eyelids along with a flow fracture. We repaired the flow fracture, and we sort of went in and formed the phonics with phonics forming sutures, and he was able to retain a prosthesis after that. Now, ptosis after surgery is very common, and this can be addressed by a prosthesis modification or correction of the volume, and fascinella servat or a muellerectomy, more specifically a muellerectomy, actually works very well in these conditions. Now, the implant can also migrate here and there. However, if the volume is actually adequate with a prosthesis sitting over it, you don't need to really do anything. But if it is causing issues with the prosthesis, that is the customized shell, in that case, you would have to sort of go in and make sure that you implant a new implant in the correct position. Now, the most disastrous of all, that is the contracted socket, which can be mild, moderate, or severe. And of course, there are various classifications for this. The reasons that you might get a contracted socket is loss of conjunctiva or inadequate dissection during the initial surgery, or when the patient doesn't use the conformer in the early post-operative period, or a poor prosthesis, or if the patient doesn't use the prosthesis often enough. So the late causes are again the migration and extrusion of the implant, multiple surgeries, radiation, etc., or an ill-fitting prosthesis. Now, how to prevent this at the time of surgery? So preserve as much conjunctiva as possible, minimize dissection in the fornices, limit the amount of cautery that you use during evisceration, and of course, making sure that the patient is compliant with their conformer or their artificial eye after surgery. So we evaluate the eyelids, the status of the socket and the prosthesis, and look for any associated abnormalities which may be causing issues with retention of prosthesis as well, such as symlephera, granuloma, etc. In mild socket contracture, you of course have to address the eyelid, and you can go ahead and put in any spacer grafts in the eyelid as required. But in moderate socket contracture, you will have a tilting of the prosthesis with extrusion. You will have a shallow superior fornix as well. So a mucous membrane graft does really well. So along with the mucous membrane graft, once you get the surface, you can add to the volume as required. And of course, most importantly, to form the fornices as well. Now, coming to amniotic membrane implant or a transplant, it is not actually a replacement for the mucous membrane graft because it is actually a substrate implant, not a substitute tissue. So it's important that we use it as a supplementary tissue rather than a alternative to mucous membrane graft. Coming to dermis fat graft, very nice, simple procedure, but fraught with complications if not dealt with properly or if not operated well. The good thing about this procedure is that you can get a nice volume as well as a good surface with this procedure. But most importantly, like I've demonstrated here, you need to have a good fornix formation at the end of surgery. They can undergo atrophy, they can undergo ulceration, infection, and melt away completely. But these can be prevented if you do a good surgery along with proper suturing all around the graft. In severe contracture, there is horizontal shortening of the lid as well as vertical fornicial shortening and the retraction of tissues because of chronic loss of orbital volume. It can be moist or it can be dry. Now, certain children have required this kind of epidermal graft wherein all things have been tried and then finally this is the only way to help them retain a prosthesis. Other issues like granulomas, they can be excised. Symlephera can undergo Z-plasties and along with a mucous membrane graft. Cysts, once you image them, they can be dealt with by either excision or with sclerosants, like how we have done here, wherein a sclerosing agent, that is sodium tetradecyl sulfate, we injected that after removing the fluid of this conjunctival cyst after evisceration, and the patient did well later, and we went on to correct his residual ptosis. So entropion is another issue which can happen, for which you would treat with a tarsal rotation and if required a mucous membrane grafting. Ectropion again can result if there is a heavy prosthesis or a lower lid laxity. Again, that you would ideally treat with a tightening of the lateral canthal tendon and a mucous membrane graft if required. Now, if there is persistent failure of surgery, you may need to use tinted lenses or the kind of spectacle prosthesis that the ocularists have come up with. So that makes it look like the other eye. So the patient can just, instead of undergoing multiple surgeries, they can just wear the glasses which mirror the other eye. So this is just an overall outline of all the issues. I've just tried to highlight it in this slide. You can always go through it later, playing the video on YouTube. But this sort of summarizes all of it. And I would say if you do a nice meticulous surgery, you can always get good enough results in socket. Thank you.
Madam, you have to unmute.
Yes, that was a wonderful talk. So, lot
Thank
of information, very crisply dealt. So, Kasturi, you have any question to take?
Beautiful talk, Rituja. Like she had included all the points very well. Management, and especially one very challenging situation is the management of the congenital and ophthalmic socket. So this is
Yes,
another situation where we really need to sometimes take the help of the maxillofacial surgeon, because we need to expand the orbit sometimes a bit, and also the whole of the maxilla needs to be pushed down and out. So otherwise, like what Rituja has already mentioned, a very meticulous surgery can prevent many of the complication, and giving an implant or any volume augmentation during the surgery is the must, unless and until it is contraindicated, like severe panophthalmitis. Even in severe panophthalmitis, we should try to follow the patient regularly, and within 3 weeks, if we can give an implant, once the infection goes down, then it can prevent all these dreaded complications. Very nice. In fact, I should thank you, Dr. Chitra. All the presentations were very interesting, very illuminating, and very nice and refreshing and learning for all of us.
Dr. Saptagirish, you were not, we didn't hear from you at all. Are you there?
Hi, ma'am. I'm very much there, and
There's so
sorry
many.
about some of the talks because I'm driving that time.
Tapping all your energies. How would you like to summarize on this webinar?
Well, it's a nice talk. I couldn't attend all of the sessions, all the talks, because I was driving the time back home. But yeah, I got to hear some of them, and of course, Rituja's and Dr. Santosh Navar's onwards. Wonderful talks. I've got nothing much to add. I think Dr. Santosh, Dr. Kasturi, and all others added what was there to be done. Wonderful. Really nice time. I'm sorry I missed some of the earlier sessions. I'm very sorry.
You also.
Vidya? Vidya,
Yes,
you
ma'am.
have
Yes.
questions?
One final question for Rituja. Like, I've seen her videos on application of fillers for volume replacement. Would you like to give more details or expand on this topic,
Yes.
Doctor?
Yes, ma'am. So basically, what I found is in patients who have a superior sulcus deformity or enophthalmus, which is very minimal, instead of going in and going for a secondary implant, you can actually achieve good results with a high viscosity filler, like your Juvederm Voluma, wherein you inject it as a bolus in one particular area, and that sort of stays like a ball there. So it sort of augments the volume and helps in the tarsal platform show as well, especially in patients who have some amount of enophthalmus.
Okay. Okay, great.
Anything, final comments from
Just to conclude to what Dr. Rituja just said, sometimes when you have a small superior sulcus deformity, what I have done is you get these hydrogel pellets, they're expandable pellets, which we can actually push it with a spinal needle into the area that we want expansion. And we can actually mold whichever area that we want. It's very similar to Juvederm, but it's more longer term. Juvederm maybe about 18 months to 24 months, it will go away at the most. But this can stay for life. So this is another way also to augment small contracted sockets.
Yes, she also mentioned about the fornix formation and everything. Would you like to add anything more to that, sir?
No, nothing much to add. She's done a wonderful presentation, covered everything in a short time, and wonderful, good. Of course, there'll always be more modifications from every surgeon, but that depends from the way that you've learned and the way you've adapted to the changes that you've done in your practice. But nevertheless, the importance is that you know how to reconstruct the fornix at the right time and the right way.
Right, sir. Thank you.
Thank you.
So I think posterior, it's already 9:15. Everybody needs to get to dinner. So I think I really, on behalf of Eye Foundation, thank you so much, each and every one of you, expert panel and wonderful speakers. it actually appeared to me that I wasn't hearing ophthalmology, an entirely new subject in itself, and so much thoroughness and so much information. So kudos to all of you, and be sure that we'll keep calling you back again and again for our future oculoplasty meetings. Thanks so much. Vidya, anything to add?
You said it all, ma'am. Thank you.
Thank you so much. Thanks a lot. Thank you. Thank you.
Thank you,
Thank
madam.
you all.
Thank you.
so
Thank you.
much.
Thank you.
Bye.
Thank you, ma'am. Thank you, Dr.
Bye,
Vidya.
bye, bye.